About AstraZeneca yesterday.
Yeah, which is funny because I think we're just following the lead of France. I think I've been muted.
Good morning, ladies and gentlemen, distinguished guests. Welcome to the 46th KAST International Symposium on COVID-19 pandemic. My name is Tae-Sung Park, professor at Seoul National University. It is my great honor to have this opportunity to welcome all of you. Today, we are honored to be joined by distinguished speakers and guests from in and outside Korea. First, I'm pleased to introduce Professor Min-Gu Han, President of Korean Academy of Science and Technology, who is with us today to deliver the opening remarks. Please give a big hand to welcome Professor Min-Gu Han.
Welcome to the KAST International Symposium. On behalf of the Korean Academy of Science and Technology, I would like to extend my sincere appreciation to all the participants from Canada, Hong Kong, Korea, and United States. It's alphabetical order. First of all, I'm extremely grateful for Prime Minister Se-Jun Chung and the Commissioner Eun-Kyung from the Korea Disease Control and the Prevention Agency for their kind support. I also appreciate Professor Haegu Jung, Chairperson of National Research Council for Economics, Humanities, and Social Sciences, and Dr. Asep Young Chun, Director General of the Statistics Research Institute of Statistics Korea, for great partnerships for the symposium. Flattening the COVID-19 epidemic curve, like every struggle against the pandemic, is a race against the time and space. As the pandemic enters its second year, vaccines have been developed in record time, and the vaccination is already started. Stopping the pandemic from claiming millions of more human lives will require a global cooperation. And modeling COVID-19 pandemic is essential to win the COVID-19 war. Today's symposium discusses merits and shortcomings of COVID-19 pandemic modeling, practice across the countries, learn from each other, make further scientific innovation to save lives in a global scale. Last but not least, my special gratitude goes to Professor Tae-Sung Park for his wonderful efforts in organizing this symposium. I hope today's symposium not only provides the exchange of the research findings, but also helps the prevention of the spread of COVID-19. Let me now close by wishing you a delightful and fruitful symposium. Thank you.
Thank you, Professor Han. Now, Professor Haegu Jung, the Chairperson of the National Research Council for Economics, Humanities, and Social Sciences, will deliver his welcoming remarks. Ladies and gentlemen, please welcome Professor Jung with a big round of applause.
여러분 안녕하십니까? 경제인문사회연구회 이사장 정혜구입니다. 오늘 제46회 한림국제심포지엄에 직접적으로 또는 화상으로 참여해 주신 모든 분들을 환영합니다. 우선 오늘 행사를 공동으로 주최하는 한국과학기술한림원의 한민구 원장님, 그리고 바쁘신 가운데에서도 축사를 해주시는 정은경 질병관리청장님께 감사의 말씀을 드립니다. 그리고 코로나로 인한 어려움에도 불구하고 오늘 심포지엄에 참여해 주신 발표자와 토론자 여러분들께도 깊은 감사의 마음을 전합니다. 모델링에 기반한 코비드19 예측의 주제로 오늘 개최되는 심포지엄은 빅데이터와 AI 분석 기술을 바탕으로 코로나 예측 시스템을 점검하고 이를 방역, 정책, 의료 시스템에 도입하는 것에 대하여 논의하는 자리입니다. 사실 코로나19 팬데믹 사태는 전 세계 수많은 사람들에게 막대한 피해를 끼치고 있습니다. 더욱이 그 피해는 사회적 약자층에 더 크게 나타나고 있으며 따라서 사회 양극화를 더욱 심화시키고 있습니다. 비록 사회 양극화가 코로나19에서 비롯된 것은 아닐지라도 코로나19는 그것을 더욱 증폭시키는 중요한 계기로서 작용하고 있는 것입니다. 이 같은 현실에서 빅데이터와 AI 분석 기술을 활용한 과학적 대응이 코로나19 극복에 크게 기여하고 따라서 코로나로 인한 사회적 양극화를 조금이라도 줄이는 데 기여할 수 있다면 그것은 사회에 대한 과학의 기여라는 차원에서 그 의미가 매우 크다고 생각합니다. 이와 관련하여 경제인문사회연구회는 2020년 3월 세계보건기구의 코로나19 팬데믹 선언 이전부터 코로나19 대응 연구단을 구성하여 정책 대응을 위한 연구를 기획하고 수행하여 왔고 하반기에는 학계와 관련 분야의 전문가들을 포함하는 NRC 감염병 연구회를 구성하여 모델링을 포함한 다양한 연구를 기획하고 수행하여 왔습니다. 그 과정에서 NRC 감염병 연구회의 공동대표이신 박태성 서울대 교수님, 고문 역할을 해주신 전영일 통계개발원장님은 많은 도움을 주셨습니다. 그리고 오늘 토론에 참여하시는 캐나다 토론토 대학의 데이비드 앤 피스맨 교수님의 모델링 분석의 도움도 매우 컸습니다. 이 자리를 빌어 감사의 말씀을 드립니다. 나아가 경제인문사회연구회는 데이터 기반 미래 예측과 정책 지원 사업을 통하여 올해 6월 말 NRC 빅데이터 플랫폼 구축을 1차로 완료할 예정입니다. 이 플랫폼을 바탕으로 미래 예견적 국정 관리와 정책 수립 지원을 구체화해 나가고자 합니다. 끝으로 오늘 이 심포지엄이 과학을 통한 사회 문제 해결에 한 중요한 논의의 자리가 되기를 바라겠습니다. 감사합니다.
Thank you, Professor Jung. Now, please join me in welcoming Dr. Sekyun Jung, the Prime Minister of Korea, for his congratulatory remarks. Ladies and gentlemen, please welcome him with a big round of applause.
여러분 반갑습니다. 대한민국 국무총리 정세균입니다. 제46회 한림국제심포지엄의 개최를 진심으로 축하드립니다. 토론토 대학의 데이빗 피스만 교수님을 비롯하여 함께 해주신 세계의 석학 여러분들께 감사의 말씀을 드립니다. 뜻깊은 자리를 마련해 주신 한국과학기술한림원과 경제인문사회연구회 그리고 통계개발원 관계자 여러분 수고 많이 하셨습니다. 아울러 심포지엄을 제안해 주신 박태성 교수님께도 감사드립니다. 세계는 지금 코로나19라는 불확실성의 터널을 지나고 있습니다. 미래는 예측하기 힘들어졌고 변화의 속도는 더욱 가팔라졌습니다. 이러한 불확실성을 헤쳐나갈 수 있는 해법이 바로 데이터입니다. 우리는 코로나19에 대응하면서 불확실성에 효과적으로 대응하는 방법을 배웠습니다. 통신 데이터와 금융 데이터를 활용해 역학조사를 실시하고 인공지능 시뮬레이션으로 사회적 거리두기의 방역 효과도 예측했습니다. 데이터 기술이 모든 분야와 융합되면서 혁신적인 변화가 나타나고 우리 일상이 크게 바뀌고 있습니다. 이제 기존의 수리와 통계, 역학을 넘어 빅데이터와 인공지능을 활용하는 역량이 국가 경쟁력의 척도가 되었습니다. 그런 의미에서 국내외 석학 여러분이 모여 코로나19 예측 시스템을 논의하는 이 자리가 참으로 소중합니다. 정부는 K 방역을 넘어 K 회복의 성공을 위해 오늘 심포지엄에서 만들어주실 좋은 아이디어와 고견을 귀담아 듣고 정부 정책에 반영하도록 노력하겠습니다. 다시 한번 제46회 한림국제심포지엄의 개최를 축하드리며 이 자리에서 모여진 집단지성이 K-회복을 넘어 세계 회복을 앞당기는 마중물이 되기를 기대합니다. 감사합니다.
Thank you, Prime Minister, for your welcoming remarks. Now, I'd like to invite Dr. Eun Kyung-jong, Commissioner of the Korea Disease Control and Prevention Agency, to deliver congratulatory remarks. Ladies and gentlemen, please welcome her with a warm round of applause.
안녕하십니까. 질병관리청장 정은경입니다. 코로나19 예측 모델링 국제 심포지엄 개최를 진심으로 축하드립니다. 코로나19를 극복하여 더 나은 세상을 만들기 위해 코로나19 예측 연구에 기여해온 국내외 석학 여러분께도 깊은 감사의 말씀을 드립니다. 국제사회는 코로나19 대유행으로 많은 인명피해와 사회경제적 침체로 큰 어려움에 직면해 있으며 국가 간의 협력이 어느 때보다 중요한 시기입니다. 그동안 인류가 수많은 위기를 이겨내며 더 나은 세상을 만들어 왔듯이 지금 우리 앞에 닥친 코로나19 위기도 성숙한 시민의식과 위대한 지성으로 반드시 극복해낼 것이라 생각합니다. 대한민국은 국민 모두가 한마음으로 합심하여 국가 위기를 대처해왔습니다. 국민의 적극적인 협력과 참여, 의료진과 방역 공무원의 헌신, 범정부 대응으로 대규모 사회 통제 없이 효과적으로 코로나19 유행을 통제해 오고 있습니다. 또한 국내 예측 전문가들의 수리과학적 모델, 빅데이터 등의 다양한 연구 결과를 활용하여 과학적 근거에 기반한 정책 추진과 선제적 대응을 위해 노력하고 있습니다. 질병관리청은 코로나19를 대응하면서 축적된 방역 경험과 정보를 민간 전문가들과 지속적으로 공유하고 과학적 근거 기반의 방역 정책을 더욱 강화해 나가겠습니다. 이번 심포지움을 통해 코로나19 극복에 도움이 되는 많은 연구 성과물과 경험이 공유되며 코로나19를 극복할 수 있는 방향과 근거를 제시할 수 있기를 기대합니다. 어려운 여건에서도 뜻깊은 행사를 준비해 주신 한국과학기술한림원, 경제인문사회연구회, 통계개발원 관계자 여러분께도 깊이 감사를 드립니다. 감사합니다.
Thank you, Dr. Jung. We now begin the first session of the symposium. In this session, we will discuss about the pandemic prediction sciences, merits, and challenges with distinguished speakers and discussants from Korea, Canada, USA, and Hong Kong. I will introduce the first two speakers, and then Dr. Young-jun, who is the Director General of the Statistics Research Institute of Statistics Korea, will gonna introduce the remainder of the speakers. Please let me introduce our first speaker, Dr. Sung-il Jo, who is the professor at Graduate School of Public Health at Seoul National University. Please welcome Professor Jo.
Good morning, good afternoon, good evening, depending on wherever you are in the world now. It's my great pleasure and honor to participate in this wonderful symposium with eminent scholars today. I'm an epidemiologist in Seoul National University, and I'm very happy to share some of the work with my colleagues, Dr. Kyung-deok Min and Sang-woo Park. In terms of incidence of COVID-19 per million, per population, Korea has been doing a relatively good job keeping the incidence below 10, recently 10 per million. And on the other hand, Korea has been relatively slower in adopting, implementing vaccination across the country compared to many other countries, partly because the cost of waiting has been considered relatively low for Korea. The number of cases in Korea is concentrated a lot in metropolitan regions where about half of the Korean people live, but the pattern of the epidemic is very similar between metropolitan regions and non-metropolitan regions, except that the scale is a little bit higher in metropolitan regions. For vaccination information, KCDA, Korean Disease Control Agency, is almost real-time providing the information of the implementation status. And from late February this year, vaccination has been expanding over the country, somewhat slowly at the first time, but catching up with faster speed right now. An initial rough calculation about the endpoint of vaccination is assuming R0, reproductive number, basic reproductive number of 3, herd immunity may be achieved by 70% of effective coverage. So with average, assuming average effectiveness of vaccination over 80%, about vaccination compliance of 90% will make the effective coverage more than 70%. So that will be part of the vision for the vaccination of the country. And KCDA has published the schedules throughout the early first half of the year with fairly detailed plans for first the vulnerable population, second to the older groups in the general population, and so on. The planned speed of vaccination is about 150,000 doses per day, which is faster than the initial speed. So our practical research questions around this situation includes, first, about the benefits of the vaccination, which should be pretty obvious. But with some modeling exercise, we wanted to get inspiration from the plans. And second, the effectiveness, the role of social distancing along with the vaccination plan, and the effect of either faster or slower vaccination speed, and either higher or lower vaccination compliance. And finally, many people are curious when we can actually end social distancing intervention that becomes a great challenge to continue a very long time. So our modeling is based on basically the standard SEIR model with vaccination component, allowing two-dose vaccination schedule as well as one-dose schedule. And we applied standard assumptions based on assumptions of the parameters based on the early publications or Korean data. And we set up the model to have subpopulation of metropolitan and non-metropolitan region with betas within and between the regions. And vaccine parameters are mainly based on the KCDC schedule. And currently, the planned schedule of 150,000 doses per day, and we compared faster or slower speed. And the kinds of vaccines may be a matter, but generally KCDA has a relatively established schedule with the timing and doses available by different kinds. So we took some average assumption across with the plans. And our model calibration seems to fit for the baseline model fairly reasonably for metropolitan and non-metropolitan areas. And one issue is the social distancing policy stringency. In Korea, Korean government has been adapting, taking adaptive stringency levels from 1, the lowest, to so far 2.5 as the highest level. And this adaptive schedule is based on the number of cases, instance of the country, and also diversified between metropolitan and non-metropolitan areas, as you see in the slides. And we simplified the assumptions of the policy levels with 4 levels. So for our results, this graph, our results is going to be presented with this format. This right-hand lower panel shows the proportion of vaccinated people, reflecting the speed of vaccination implementation. And compared to no vaccination policy, current implementation's coverage will lower the cases, lower the number of cases, and by the adaptive policy level, enable lowering the, relaxing the social distancing stringency level. And some numerical interpretation shows the vaccination will reduce the number of cases during this year, as well as the policy strength can be lowered in the lower and will remain longer in the lower steps. The next question is whether the social distancing interventions can be changed. We tested just one other assumption, that whether if social distancing policy, rather than taking the adaptive policy, if it's remaining in the strict, relatively strict level, that will actually result in faster decline and faster end of the social distancing intervention with the current vaccination schedule. But there is, of course, there is a challenge of maintaining stronger distancing policy with lower or slower or faster speed of vaccination schedule represented in these lines. With slower, the decline of the resolution of the epidemic will be slower, whereas faster vaccination speed coverage will enable more relaxed social distancing policy, as well as reasonable achievement of the goal. And about the compliance, for this year, we only assumed 80% and 60% compliance, but during this year, the problems of low compliance rate up to this level may not be obvious, because it can be delayed while coverage expands among those who are willing to be vaccinated. But the compliance matters about the timing when social distancing intervention could end. With vaccination, if social distancing policy ends too early, it may lead to another wave until the vaccination coverage meets the final goal. And with lower compliance, there may be even another expansion. So that may be a little more serious than slower speed, because the final compliance rate will determine whether we can actually end the epidemic or not. And also, faster vaccination rate with appropriate coverage of social distancing policy will work together to achieve relatively early social distancing policy completion. So both aspects are very important. So in summary, our model shows that vaccination is definitely effective in lowering the incidence, but if faster than current schedule, the faster speed of the vaccination coverage than current schedule, if that's possible, that will be more beneficial in ending relaxing social distance intervention, and also lower compliance would be important factor in the later stage, so that considering this compliance maintenance is very important. Thank you for your attention. This is the end of my talk. Thank you.
Thank you, Dr. Zhou, for sharing also with your work on social distance and vaccine effect. Now I'd like to move to the next speaker, Professor Eun-ok Jung, Department of Mathematics, at Konkuk University. She's going to talking about also the vaccine priority strategy in Korea. Now it's your turn, Professor Jung.
Hi, everybody. I'm Eun-ok Jung in Konkuk University. Today, I would like to introduce the prediction and also vaccine strategy of COVID-19 in Korea using mathematical modeling. Okay, let's start with the prediction. So we consider very simple SEI-QR model first, and Q is isolated group, and most of parameters including latent period, infectious period, quarantined period from the epidemic references, except the transmission rate. So we consider time-dependent, actually policy-dependent transmission rate, and we start simulations on February 16, 2020. That was the day when first case occurred in the community. And all confirmed cases will be quarantined at the same time as they confirmed, and we don't consider latent period transmission. Okay, so we are experiencing third wave of COVID-19 in Korea. These are the very dynamic change of social distancing level by Korean government. So right now we are in social distancing level 2 in a metropolitan area, including Seoul. And as you can see, the outbreak stables. The reproductive number is about 1, right here and here. Currently, the reproductive number is about 1, but the scale of the mean daily incidence is about 400. So there is a risk to occur another outbreak. So we have to be careful. Okay, so we can predict using this RT. So if we extend it, current RT, that's about 1 for 2 weeks, then this is more similar. However, if we extend the maximum RT after third wave for 2 weeks, then we might have the mean daily incidence over 1,000 by 2 weeks. Okay, this SEIR model is pretty good to estimate reproductive number for short time. But I liked this model better. So we consider behavior changes. So here we live like this before COVID-19. However, the cases is exponentially increased during first wave. People changed behavior a lot. So they move from susceptible to behavior changes susceptible group. So in our model, we consider 3 susceptible groups: normal susceptible, enhanced social distancing group, SF, and distancing in life group. And also we introduce 2 more parameters, delta and beta F. Delta represents the transmission reduction rate of behavior changed individuals. And beta F is the kind of speed from S or SL to enhanced social distancing group. So these represent like a strength or speed of behavior changes by social distancing. But there is time limitation today, so I would like to just introduce the result of prediction. Since RT is about 1 currently, the result is very similar one from SEIR model. However, if RT is much greater than 1, like 1.5, 1.7, then the results from behavior change model and SEIR model are quite different. Okay, so let's move to vaccine strategy. This work has been supported by the KCDC. So here we consider 4 groups. The group 1 represents house care workers, and group 2 is underage, under 20s, and adult group, excluding house care workers. And group 4 represents the senior group, over 70 years. And there is no data for contact metrics, right? In Korea, actually most of countries. So we used maximum likelihood estimation to estimate the transmission rate between heterogeneous population group. Since we have now the specific data of confirmed individuals from the KCDC, we can calculate the probability that each patient will be confirmed on the real date of confirmation. And by calculating the likelihood like this, we can estimate the transmission rates that maximize this likelihood. And this is the result. As you can see, this is quite different from one in the 2009 influenza pandemic. In 2009, this is underage group. The underage, the transmission rate is highest than other entries. However, in COVID-19, this underage transmission rate is pretty low. That's because the school opening delayed, and also the student has to take the online classes. Furthermore, the mass outbreak events at the elderly care facilities were also reflected in these metrics, like here, higher transmission rates among senior group and between the house care to senior groups in Korea. It's quite different, right? So, yeah, but this transmission metrics using MLE is mean value over 1 year. So we introduce beta 0T here. That's time-dependent constant. That is considered to reflect time-dependent government interventions and also behavior changes of population. So these are the results from this heterogenic population model. And this is reproductive number. As you can see, this is a pretty similar result, one from SEIR model. Okay, now using this model, we consider also vaccination. So we add 3 more compartments, U, V, and P. So U is in effectively vaccinated compartment, and V represent effectively vaccinated. And it takes time to get immunity, so the P is a protected compartment. In this simulation, we assume the vaccine efficacy is about 70% or 90%, and it takes about 2 weeks to get immunity. In all scenarios, the total dose for healthcare workers is fixed as 0.5 million because the number of healthcare workers is less than 0.6 million in Korea. And doses for other groups are set as 1 million here, and 1.5 million and 2 million. And daily doses are assumed as 0.1 million or 0.2 million. We also consider the reproductive number from 0.1 up to 2. So total scenarios we considered are 120 cases. Okay, and these are the results with vaccine effectiveness 70%. So each color represents different order of vaccination. Okay, so Korean government started vaccination from February 25th this year, and reproductive number is about 1. Okay, and in Korea, to minimize mortality, the vaccination was planned with priority to healthcare workers and elderly people. So if you see this star mark, the simulation results actually consist with the Korean policy. So by the way, this is the case with minimizing incidence and minimizing mortality, the bottom, the graph. And vaccinating the source of the infection, that's actually adult group in Korea, was the best strategy to minimize the incidence. Look at the green color. Okay. However, if reproductive number is greater than certain number, like over 1.3 or 1.4, then color is changed, right, to green color. So the green color has the order of adult, healthcare, senior, underage. So our simulation result shows that the priority changed according to the reproductive number. But it's not easy to change the policy, right? So in order to maintain the current Korean government vaccination policy, it's important to continue strong non-pharmaceutical interventions, such as enhanced social distancing during vaccination time. If we consider vaccine effectiveness 90%, the blue color is moved to a little bit right-hand side, but the result is qualitatively similar to previous one. Okay, so if we just consider one case with vaccine effectiveness 90%, total 5 million dose, and daily 0.1 million, and RT is about 1, then we might reduce additional mortality 20% for extending 100 days. Maybe we can reduce 42% if we extend like 6 months. Okay, so let me conclude. So mathematical modeling is very powerful tool to do prediction of emerging infectious disease, and also we can give the science base for preemptive and effective prevention policy. Let me just emphasize this one more time. So this study actually revealed that in order to maintain the current Korean policy, vaccine policy, it's really important to ensure that the reproductive number does not exceed the threshold by concurrently implementing non-pharmaceutical intervention such as social distancing. Okay, thank you so much for your attention. Thank you.
Thank you, Unok. We are in the middle of the first section entitled Pandemic Prediction Science, Merits and Challenges. I'm co-chairing this section with Professor Tae-sung Park with Seoul National University. I'd just like to remind you, you are in the middle of this first section. We have two more speakers, David Fishman and Christopher Murray, and followed by a discussion with Gabriel Leung with Hong Kong University, and also Simon Johnson with MIT. And we are going to have the Q&A section with all those discussion points together. So let me introduce the next speaker, David Fishman. He's a professor at the University of Toronto, based in Canada. I think that he's I'd just like to tell you that he's a physician and epidemiologist with his interest in intersectional, I think, the science of epidemiology, mathematical modeling, and health economics. And I'd just like to tell you that how grateful we are to David Fishman, because he's been working with Korea since the outbreak of this COVID-19 in February 2020. So we've been working together to have all this prediction together between U of Toronto and many other colleagues here in Korea. So welcome, David, and then please get to this your presentation.
Thank you very much. I hope you can see my slides all right now. Before I start, I don't want to be too sort of sentimental, but I did want to say that this has sort of been, in a lot of ways, the best of times and the worst of times. It's obviously a terrible thing that we're going through globally right now, but there have been some really unique experiences and some very interesting and wonderful connections made. And for me personally, the connections with Korean colleagues are very, very high on the list. It's been a privilege to get to know Asaf, and it's been a privilege to get to know Paul Choi a little bit and to work with them. I'm looking very forward to continuing to do that after the pandemic. And without further ado, I want to talk about something in which Korea has excelled, which is testing, and how testing changes the way we see a pandemic. So just in terms of disclosures, I have funding from Health Canada and Canadian Institutes for Health Research. I sit on advisory boards for Pfizer and AstraZeneca, and also for Securus flu vaccines. And I've also served as a consultant for some different groups listed there during the course of this pandemic. The work I'm going to present is collaborative. It represents work done with Professor Amy Greer at University of Guelph and Professor Ashley Chute at University of Toronto. So here we are, and I think we've seen a picture like this already. If we look at the where we are globally in terms of counted cases over the past year, on the x-axis in this graph we have the date. We've come through a rather rough winter with a second wave peaking at about 800,000 cases a day. Things subsided through January and February, and now we have a variant-driven third wave with a global reproduction number that looks like it's somewhere between 1.5 and 2. What we see, though, is the tip of the iceberg. On the left-hand side here is a cumulative meta-analysis. This is unpublished, but it's something that I sort of had done as a back-of-the-envelope exercise back last April, May, looking at what fraction, when seroprevalence studies started to come out, how did seroprevalence in different countries compare to counted cases in those countries. And what we started to see is that, well, we probably identify somewhere between 5 and 10% of the infections that are happening globally, perhaps higher or lower in different regions. So we don't see all of it. We see the tip of this iceberg. In Canada, just to switch gears, in Canada, we have a very different epidemic than you're experiencing in Korea. We have our daily case counts are about an order of magnitude higher. Green is Korea here, black is Canada. And I am in the province of Ontario. Canada is a very big country. It's the second largest landmass country in the world by land mass, but most of it's very sparsely inhabited. I'm in this pink province here, Ontario, which we can blow up. And we can see that Ontario is actually also mostly very sparsely inhabited. Most people in Ontario live in southern Ontario. So this province has a population of about 15 million. 94% of those 15 million are in southern Ontario, and fully 1/3 of that 94% are here, which is the greater Toronto area, and another 1.5 million are in Ottawa. This map is not by population, it's actually by density of COVID cases in December of 2020. So you can see very much as in Korea, our hotspots are really in our cities. As of a few days ago, we hit the 350,000 counted case mark in Ontario. That's about 1/3 of the million cases or so we have in Canada. And we've at that time had lost about 7,500 people to this disease. It's very heterogeneous. I won't go into this in detail, except to say that these are 34 different health units that we have in Ontario, and you can see that they're all very different pictures. It's some are we have our own little versions of New Zealand or Korea in Kingston, and then we have Peel, which is a region in Toronto that has really struggled, and everything in between. But just to tell you the story of the pandemic and how it has looked in Ontario, Canada, we're fortunate here because we have case counts, and here I've plotted case counts. This is from March 2020 by age. And what we can see is that last spring, what we saw was an epidemic that looked like it was almost entirely focused in the elderly. This dark blue curve represents mostly outbreaks in long-term care facilities. And we were testing a lot. This second panel represents tests. And we're very fortunate in Ontario because we have a single authority, a single public health lab that tells us how many tests we're doing. So we're able to look at test volumes. Over time, test volumes in all other age groups have risen markedly. This represents a testing blitz during the long-term care outbreaks. And this red curve here represents return to school last September, where there was an attempt to test very widely in kids in school, and the lab became overloaded and had to stop because we couldn't maintain that sort of testing volume. Down here in the bottom panel, what we have is percent positivity with a lot of variability in testing rates. That can obviously drive a lot of variability in what we see in terms of cases, and that'll be the basis of the work that I show you. I just wanted to show you the end part of the story because the previous slide starts in March. This is a slide that starts a little bit later and extends a little bit later so that you can see where we're at now. What we've had happen in Ontario is we had our big winter wave. Things have subsided, and now we seem to be on our way back up again with a surge that's very much driven by B117, which is now 70% of isolates, new isolates in Ontario are B117. We do have a success story in that cases, and particularly deaths, in older individuals, you can see in this top panel, the 80 and over group has declined fairly markedly and hasn't risen as rapidly as others because vaccination prioritized long-term care facilities where we were having a lot of our deaths. And you can see there's tremendous variability in testing. Red and orange are kids in school. Blue is elderly individuals, and the rest of these curves are testing in other adult age groups. So what we can do, what we should see in a pandemic, and this is a bit of a conundrum, and this luxury that we have in Ontario, the fact that we do actually track how many people in each age group we're testing gives us this luxury. What we would expect to see in a pandemic is we would expect to see standardized morbidity ratios that are proportionate to contact patterns. And Professor Jung mentioned contact patterns in Korea. And what we expect to see with a pandemic disease is if everybody is susceptible, then attack rates should reflect how much interaction there is between different age groups. So what we should actually see is a standardized morbidity ratio curve that's elevated in young people. This is standardized ratios by age group. What you see is the opposite. If we look at number of cases by age group divided by the rate of cases in the population as a whole to standardize, what we see is very low cases in the youngest individuals, higher in the 20-year-olds, and then declining through the life course, and then very high again in older individuals. But that actually parallels, we can do the same thing with testing. We can calculate standardized testing ratios where we look at the rate of testing by age group, and this is also by sex, rate of testing by age group and sex in different age groups. And what we see is that this is the same shape. So what we're actually seeing in terms of risk reflects who we are testing. And then in this bottom panel, what we have here is standardized test positivity, where we take test positivity in a given age group and we divide it by test positivity in the population overall. And here we get a bit of a different looking shape. And this is de facto adjusting for test frequency. So, we have to come up with ways to sort of think about how we're going to adjust for the fact that we test differentially across the life course across ages. And we undertest kids. We know we undertest kids. This is a sort of a reference to my favorite band, The Who had an album called The Kids Are All Right. And that's been one of the silver linings of COVID, is that the kids have mostly been all right. Morbidity and mortality appear to be far lower in children than in adults. ICU admission and deaths do occur, but they're very rare. Hyperinflammatory syndrome occurs, and long COVID remains an important concern that we don't understand yet in kids. But overwhelmingly, the toll in children has been much less than in adults. But we know asymptomatic infection has been recognized in children since very early in this epidemic. I think this is an initial publication from Shenzhen in China with a family cluster outside of Wuhan, where the index case may have been an asymptomatic 12-year-old with pulmonary disease. So infection in kids and minimally symptomatic infection in kids has been recognized from the outset of the pandemic. And if we look, this is some work that we did over the summer, if we look at the likelihood of being recognized as an asymptomatic case in an outbreak investigation, children under 10 are much more likely in Ontario to be identified as asymptomatic when they do outbreak investigations. So what we would expect is that kids are going to get tested less because they're less likely to be clinically sick. So an idea came up. This is actually built on some ideas from other groups about how to estimate infection fatality ratios. What we see in our data is we see a strong relationship between standardized morbidity ratio, that's the risk of infection or being a case in a given age group relative to the population as a whole, and standardized testing ratios. That's the likelihood of being tested in a given group relative to testing in the population as a whole. And what we can do is we can regress these one on the other. We can do, regression models for each age and sex group that's of interest. And if we regress SMR on STR, or in this case, log of STR, what we see is that when log of STR is 0, that's when the standardized testing ratio is 1, log of 1 is 0. What happens is the beta coefficient drops out of this model and we're left with an intercept-only model. So what we can see is that when a given age and sex group is tested at the same rate as the population as a whole, the intercept from that model becomes a good estimate of test-adjusted standardized morbidity ratio. And so that's a trick that we've applied to some data from Ontario to sort of adjust our data and see what happens after we account for differential testing by age. Just looking at the time. And this is what we get. And this table is obviously, this is not a good thing to present as a table. I should present this as a graph, which I will on the next slide. But what we can see is in terms of the standardized morbidity ratios after we adjust for testing, is the SMRs are lower in kids. This is the 0 to 9 age group in this top row. But they're approximately the same as what we see in the oldest, oops, a daisy, just have to move this bar out of the way, in the oldest age group. So we have an SMR of around 0.6 in the youngest kids, and we have an SMR of about 0.5 or 0.6 or 0.7 in adults aged greater than 70. So that looks quite different than our initial sort of crude estimate of what the SMR was, where older adults seem to be at much greater risk. In fact, they're at the same risk as the youngest kids. And what we see with older kids, with teenagers, is that they are at higher risk than the population as a whole. They have elevated SMRs. That increases further in young adults. And what we see in young adults, particularly in young men, is this diverges sharply by sex. So young men actually have an SMR test adjusted that's 2.5. It is 2.5. So once we adjust for frequency of testing because they're under tested, we'd estimate that they're being infected at a rate 2.5 times that of the population as a whole. And we can take this and we can apply this back. We can anchor this on our most tested group, which our most tested group per capita is 80 and over year old women. And we can say, well, if we tested everybody, so we can assume that that's our most accurate estimate of incidence. The most highly tested group is the 80 and overs, the females. And if we anchor on that rate, then we can back into estimates of cumulative incidence by age and sex. And what we see is, again, we see that estimated cumulative incidence sort of declines from youngest to oldest, rather than going up from youngest to oldest, with the youngest individuals in the population, again, infected at about the same rate as the very oldest. So we have a decrease at the extremes of age, and then in the middle, we get this sort of diagonal decline. This is some older work, and I'm sorry, it's a bit blurry, looking at a standardized morbidity ratio from regression. That's this brick-colored line, and comparing it to some serology data from blood donors, unfortunately, which starts at age 20. So we don't have kid blood donor data, of course. But this actually correlates pretty well. And more laterally, what we've done, because we don't have serologic data, is we've looked at correlation between this regression-based approach and standardized positivity ratios. And they're very highly correlated. So, test positivity has been our go-to in terms of adjusting for frequency of testing for things like influenza. What we find is that this is highly correlated with that in terms of the estimates that we get, but it also has some advantages because it allows us to back into actual estimates of incidence, which standardized test positivity doesn't readily anyway. The last thing I'd like to talk about is how some of these insights that, the epidemic we see changes on how much we test and who we test relates to actually some local political challenges really in Ontario in the fall, where we were not testing very much. We were initially testing something like 4,000 or 5,000 people a day in the fall, and we are at 10 times that 4,000 or 5,000 people a day in the spring, and we were at 10 times that by the fall. And of course, our case numbers went up, and this fed a narrative in Ontario that this was a case-demic, that this wasn't that big a deal. So we hypothesized that, in fact, the fact that we were seeing less ICU admissions for a given daily case count was probably simply explained by increased testing volumes, as well as a shift in the mean age of cases from older to younger. And we used the testing and the case data sets in combination to create a very simple negative binomial model using 2-week lags. We regressed ICU admissions on log weekly cases, log weekly tests, not deaths, that's a mistake, and our weekly case age. Our initial model was constructed to November the 17th, 2020, and then we've been able to come back, here are the coefficients. So the more cases we have, the more ICU admissions we have at a 2-week lag. The more tests we have, the fewer ICU admissions we have. And as cases get older, ICU admissions increase, and we're able to turn that into a score. But just to show you how nicely this does, the line here is the model prediction, and the dots are the initial derivation, and then we had a few weeks to validate this back in the fall, or the white dots. And this did very nicely in terms of explanatory power, in terms of explaining what we were seeing with the ICUs. What's neat is we've been able to rerun it, and I've just sort of rerun this this morning. And we see that it's held up very well. So the predictive validity of this very simple model is good. And incorporating testing really does allow us to predict how much traffic we're going to see in the ICU. And again, the lines here are the model, and the dots are what we've seen in terms of weekly ICU admissions. And in terms of future work with this, the questions obviously, is this generalizable, or is this just a trick that you can do in Ontario? We do have some colleagues who have validated this in British Columbia, but it doesn't seem to work in Quebec for whatever reason. We say in Canada that Quebec is a distinct society, and it seems to be a distinct society in this respect as well. We can also use this. We've got some ongoing work to try to figure out what the true length of stay is in the ICU, because our data have some limitations that I won't get into right now. So in conclusion, the volume of testing is something that people don't tend to think about, and often is not available. But the volume of testing determines how we see epidemics. And the availability of test denominators allows us to adjust for undertesting. Both gives us a more accurate, we think, a more accurate picture of what's going on with kids in populations with decreased severity, and it also lets us accurately forecast severe illness when testing expands and captures people who are at lower risk of severe illness. And with that, I will end. There's my contact information for anyone who wants it. And again, thanks so much for the opportunity to speak here. It's such an honor.
Thank you, David. I think we are very fortunate, I think, to have David speaking with us today. And I just like to tell you, all this virtual audience, David is the man, actually, many scientists and journalists actually approached when it comes to the initial outbreak of this pandemic back in the spring of last year. So if you Google David Fishman, you can find his great work in Washington Post, New York Times, and many others, because he's the man who actually warned about this crisis and how fastly this is going to spread out to the rest of the world. Even back in March and April last year. And then many people across the United States and then many other people in European countries actually listened to him, and then actually listened to his advice and about how to handle this crisis. So he's the man actually who has done that kind of work way early. So with that, I'd like to turn to the next speaker, Professor Christopher Murray, and he's the professor of the Health Metrics Science at the University of Washington. He's the founding director of the Institute for Health Metrics and Evaluation. He is a physician and health economist by training, and he also served as executive director of the WHO evidence and information for a policy cluster years ago. And he also served as a director of the Harvard Initiative for Global Health. And we are very, I think, pleased and then very privileged to have the Christopher to speak with us today. So Christopher, this is your time for next 20 minutes.
Okay.
The time.
Thank you very much. I'm going to talk about the experience of modeling the pandemic at IHME over the last year. We produce estimates every week for every country in the world. And I'm going to walk through some of the various steps and challenges that have come up during the course of the pandemic, some which will resonate rather nicely with what Professor Fissman was just talking about. So we've actually gone through 5 models, and I won't belabor the details of the 5 models, just to say that as the epidemic has unfolded, particularly more recently with the advent in the fall of the prospect of vaccination, the challenge of understanding infections given issues around testing that we've heard about, and also now the issue around cross-variant immunity. We've had 5 iterations of the model, and we'll continue adapting the model as we learn more about the pandemic. So we started in our 2nd generation model, which was sort of 4 weeks into the epidemic, with a basic transmission dynamics model. And the key thing here is that the pace at which you move from susceptible to exposed was governed in our model, and still is, by a series of variables that predict that transmission. And one of the key drivers, and one of the sort of really interesting advents in the epidemic, has been the use of cell phone-derived mobility data that we process from 4 or 5 different groups that make it available on a weekly basis, and get curves like this, and a map on the right for the United States, showing the trend in mobility compared to the pre-COVID baseline. And that's a key covariate for transmission, and is held up as we rerun these regressions every week for the last year. Second, another variable that has remained a very strong predictor of transmission, and is in the regression part of transmission accounting for past infections, is mask use. We've been fortunate that the Facebook daily survey program now includes and has included questions on mask use. So that gives us a daily read on the trends in mask reuse by country. There's issues around selection bias and who uses Facebook, but the Facebook results match well with other smaller surveys that are done on a random sample basis. Another variable that, starting at the end of April last year, started to come through in our regressions. We were told at the beginning that, other than Mark, who's on this group as well, who was talking about seasonality very early on, but many people didn't believe in seasonality. We found in our regressions of transmission dynamics that seasonality was quite strong, partly because we were analyzing the whole world at the same time, and so the Southern Hemisphere contrasting to the North had that come through, and that has remained an important predictor, and is going to be very important for the near term. Now, both directly in the regressions, but also as a predictor of mobility, is the issue of social distancing mandates. And so we track, and we have quite a data effort to track 25 different social distancing mandates by day for every country in the world. That takes quite a bit of staff time to do that. But it gives us this matrix of day and social distancing mandates, and we can use them both to predict mobility, but also to predict transmission above and beyond mobility. And probably in about 2 weeks, our model will not only use the mandates to predict mobility and then mobility onto transmission, but we will have the mandates directly in the model. Our testing to date suggests that improves model performance in terms of predicting transmission. Now, we just heard about the importance of testing, and we realized this early on, and initially said we were going to focus on what we thought was measured better, which was death, because what testing was available was preferentially used to detect the more severely ill patients in hospital. As time has gone by, we've learned about lots and lots of reporting lags in death data that are quite problematic. And so now we triangulate to get past infections using cases, hospitalizations, and deaths. And we take the 700 or 800 seroprevalence surveys to derive the relationship between cases and the testing rate. And so here's just an example of the infection detection rate based on the analysis of seroprevalence data on time. And I could have just as well shown you what we actually use in the regression, which is the infection detection rate as a function of testing. And that's how we get our estimated infection detection rate and convert cases into infections. Same thing for hospitalizations, same thing for deaths. Here's the infection hospitalization rate in the US, quite variable by state, but still it's stayed relatively constant over the course of the epidemic, as opposed to the IDR, which has gone up over the course of the epidemic as testing has become more widely available. So this is how we get infections. We produce these plots for every location in the world that we model, which is about 800. And we produce these as the sort of first step in the weekly modeling process. On the top left is cases, middle in blue is hospitalizations, and the bottom is deaths. Our estimates of the infection detection rate, infection hospitalization rate, and IFR, the infection fatality rate, for each location in the middle. And then we map each of those into daily infections. And then as a visual sort of validation, we can compare cumulative infections to the seroprevalence survey that we have available on the bottom right. And this is what we end up using that process. We still haven't gone to any transmission dynamics modeling. This is still just an empirical assessment of the past of the percent who are infected. This will have a pretty big change in the next week, because we've been testing over the last 3 to 4 weeks a detailed analysis of what is the assay that each seroprevalence survey has used. We now know curves for the dropping off of sensitivity over time, and we will do an assay-specific correction of the seroprevalence data. In the US, for example, it increases the total percent infected from about 21% now to about 26% when we do that, but has very different effects in different places because different assays are much worse or better than others. So, for example, the antinucleocapsid assays are quite poor, and they tend to wane pretty radically over the course of even 6 months. Okay, so that's how we have our basic model. In the fall, in October, and then we released in November, we had to add vaccination because we knew the vaccines would be coming. And so we added vaccination by elaborating the SEIR model. It's a little more complicated than we showed here because we track low risk and high risk to take into account the differential infection fatality rate by age and the fact that vaccination strategies would focus on the elderly in some countries or the high risk. So that's built in as well. And of course, we need to understand both demand for vaccination, that is vaccine confidence, as well as vaccine supply. So we run each week using the Facebook data and some other sources. They align rather well with, for example, the work that's being done by Heidi Larson on vaccine confidence. We process the vaccine, the percent of the population willing to say yes or probably yes to take a vaccine. So we get, weekly trends in vaccine confidence by location. Here's a map of vaccine confidence in the US as of about 2 weeks ago. And we update this, or as a week ago, we update this on a weekly basis. On the supply side, it's a bit harder. We use what the manufacturers tell us are pre-purchased contracts. We try to modify those as we hear about supply shortages and new purchasing agreements between countries. And so we have for each of the major vaccines by country, what we understand is the access to supply. I think the main insight on vaccination is that in the United States, as an example, we will switch from being supply constrained now to demand constrained in May. It's coming very soon. We'll hit the limit of people willing to take the vaccine pretty soon. Now, that's not the case in low and middle income countries where they will be supply constrained for a very long period of time. And in Europe, they will be supply constrained probably well into the middle of the summer. But we try to take that into account in the vaccination model. And here's an example of the vaccine scale up. The green line is the number of people that we expect to be vaccinated, and the blue line is those that are effectively vaccinated, taking into account the vaccine efficacy of the particular mix of vaccines in each country. And so you can see here that by the end of April, we're expecting to hit that limit determined by vaccine confidence in the US amongst adults. Now, a very important issue, particularly one with the spread of the new variants that has a profound effect on the models, is this issue around vaccine efficacy. We track all the trials. We also look at the post-vaccination studies and try to meta-analyze and come up with our best estimates of efficacy against wild ancestral variants and 117, and then efficacy against the escape variants, both for symptomatic disease and for infection. And this is a summary of our current assumptions. Notice, for example, that AstraZeneca has almost no effect on the escape variants from what we understand from the trials. And so that's a super important issue when you think about COVAX in the future and the spread of the escape variants. New variant scale up. We, like many, analyze the GIS AID database. There's a big lag in that database. It's about 2 weeks to 3 weeks out of date, but it is what's available. We try to filter that for small numbers. We also try to take into account adjacency in some of the transmission dynamics to get a sense of where the new variants are scaling up. This is now the dominant issue in the modeling, as I'm sure everybody is aware. And basically we have 3 epidemics: 117 widely distributed in the Northern Hemisphere and the Middle East, 351 mostly, but not exclusively in Southern Africa, and then P1 epidemic, which is the most concerning in Brazil, Peru, Ecuador, Venezuela. We have used the well-documented pace of scale up for B117 in the UK as our main model, because that's the best study. The UK's done a great job of sequencing, and it's the place that gives us the most rich spatial detail on understanding the spread of 117, both over time and across space, and that's how we've anchored our variant model. Now, the big issue, of course, that erupted in January is how much protection does natural infection with ancestral variants, or 117 for that matter, provide against the escape variants. And if you look at the surge in Amazonas in Brazil, clearly we started in a population with 70% already infected, roughly, in December, and you had a large epidemic unfold, strongly suggesting reductions in cross-variant immunity. Same thing from both the AstraZeneca and Novavax placebo arms in South Africa. So we roughly think, and I think some of the modeling by Imperial comes up with similar numbers, that cross-variant immunity is around about 30%, not 0, not 50 or 60%, and we run in our models in uncertainty range from 0 to 60%, but the midpoint is about 30%. Now, to capture cross-variant immunity, we divide the world into the ancestral variants and those that don't have escape, so non-escape variants on the left-hand side here, and the escape variants on the right-hand side. And it makes the model more complex, but still, relatively efficiently estimated. And that's the model that we currently run. Okay, what does this all mean? Well, here are some examples, and I just want to give you long-range forecasts from this model. We have run 256 scenarios where you do every combinatoric of the key drivers. What will happen to mask use after the summer when there's probably been a long lull of low transmission in the Northern Hemisphere? What will happen to mobility? What's cross-variant immunity? What will happen to vaccination rates, et cetera? And just to give you a flavor of this, this is global cases, not infections. I'm showing you cases, so it's taking into account the infection detection rate. On the left, our best approximation of what the future or the most probable amongst those 256 scenarios is the purple line. So we expect a pretty large winter surge in cases and deaths on the right-hand side. And in the worst scenario, not worst, but worse, that is lower mask use and higher mobility and everything else about the same, you get a much bigger epidemic next winter. In Western Europe, you still get this range, but here you get this incredible range where people keep wearing masks and vaccination keeps scaling up. Despite the introduction of the escape variants, nothing much will happen next winter. However, if people don't wear masks at a very high rate, which we think is not very likely, you get quite a few deaths shown in purple and quite a few cases and deaths. If you have almost no mask use and baseline mobility in Western Europe next winter, the combination of vaccine hesitancy and the transmission dynamics and the efficacy against the escape variants all adds up to quite a large epidemic. So you can easily construct in these models a pretty grim winter in the Northern Hemisphere next year. And of course, we are expecting a very grim season with the P1 epidemic now, and again with Mexico next fall. So Latin America, there's sort of a double hit here. You have what's happening now. A lot of it depends what happens in Brazil. Very hard to know when the P1 driven epidemic might get under control. And then the big question mark for Latin America is when do the escape variants show up in Mexico, which has low testing and currently rather low vaccination rates. So real potential for a huge transmission in Mexico, probably later in the year and into the winter in the Northern Hemisphere. And then lastly, for the US, there are many ways to construct scenarios where not much happens next winter. You get vaccination to kids, you get high vaccine confidence in children, you go from 75% vaccine confidence to 85 or 90% through persuasion and public information, and cross-variant immunity is higher than we think. And if you add all those together, you can construct almost nothing happening next winter, but it's quite unlikely. And we think there will be a modest or moderate epidemic in the United States next winter. It could be quite large. And I think and here's my last slide for 5 things to prepare for a non-zero probability of a winter surge in the Northern Hemisphere. These are common sense, but I think they are practical things that one can pursue in the face of so much uncertainty about what the future holds for COVID even just over the next 12 months. So I'll stop there. Thank you very much.
Thank you, Christopher. I'd just like to tell you, Professor Murray's work has been widely cited by many people, especially in the United States. When it comes to model outcomes of the COVID-19 pandemic across the United States, they go to Christopher Murray because his modeling work team has done such I think, wonderful work in the past 12 months. So if you'd like to learn about how things are in the United States and across each of the states, you can go to University of Washington website of the IHME, and then you can find a lot of good research outcomes and actual modeling outcomes. So that's the thing I'd just like to tell you about. Now, we just had 4 speakers in the line, and now we are going to turn to 2 distinguished discussants of this first section. We have first discussant, Professor Gabriel Leung. He's the Dean of University of Hong Kong School of Medicine. He also served as the Hong Kong's first Undersecretary for Food and Health. And he also, I think, served as a founding director of the WHO Center for Infectious Disease Epidemiology and then Control several years ago. So we are very honored to have Gabriel Leung with us as a discussant of those 4 presentations we just heard. So, and then we are going to have the Professor Simon Johnson, and I'll get to him in a second. But first, Gabriel, please be with us.
Thank you so much for the privilege and the opportunity to learn from our 4 very distinguished speakers. And my job is made very difficult because they've really said it all, and they are really the experts in their own fields. So what I perhaps would just like to do is to highlight a few of the commonalities across these 4 presentations, and really just to educate myself more, maybe pose a few questions that they may wish to perhaps clarify or explain in a minute. So from Professor Cho in the first presentation, we really heard a lot about the Korean planning scenarios for vaccines. So in particular, we have heard from Professor Cho about herd immunity, and that refers to the proportion of coverage that one might require in order to really stop transmission altogether. And I think that there are some opposing forces that perhaps are not quite as easily captured by the heuristic 1 minus 1 over R naught. So for example, we know that SARS-1, as well as this now SARS-2 or COVID, is very much over-dispersed. That is, it's very clumpy. So infections are clustered in certain settings, and so you get phenomena such as super spreading, but even when you have garden variety transmission chains, you see maybe 60–70% of all primary index cases not transmitting onto a secondary generation, and a very small proportion actually being responsible for 70–80–90% of secondary cases. So that, of course, should figure in how you think about the whole concept of herd immunity. The second thing that makes it very difficult, and I think Chris talked about it in his presentation, there is an Excel spreadsheet, if you remember, that he laid out the assumptions of the vaccines. And in there, one column goes to what is published by the pharmaceutical companies and the regulatory agencies, looking at essentially the primary outcome measure is symptomatic disease protection. But in fact, in a transmission model, you are really interested in protection from infection itself and therefore transmission. So there is a bit of a discount there, and depending on which vaccine, the discount probably ranges somewhere between 60–70% all the way to perhaps 80–85%. So that is something else, but it acts in the opposite direction as to this clustering effect. And then, of course, the relatively good news is Mark Lipsitch, who's going to be speaking in the next section, actually published a very, very elegant paper on the Israeli experience in the New England Journal. And of course, we read the US experience about healthcare workers and the effects of vaccines protecting against infection itself in the MMWR done by the US CDC just yesterday. So I think that that's very, very interesting as we try to now refine some of those assumptions and estimates. And I think the other big thing that we should think about is about border restrictions. I don't think that any of the speakers actually, they all talked about the PHSMs, or the public health and social measures, or the NPIs, non-pharmaceutical interventions, but border restrictions has been a very prominent feature that has actually gone against public health dogma and very much WHO guidance, even enshrined in the IHR, the International Health Regulations. Everybody has done it, but nobody has really sort of got any experience of, oh, what if we really go ahead with these vaccine passports for travel? And as economies really require resuscitation, what might happen to some of these models and some of these scenarios? And finally, I think that sort of, if we think about a worst case scenario, we may not actually be hitting herd immunity in any population because either of vaccine hesitancy or because of coverage, or in fact, you see this East Asian paradox where Korea, like many, many countries in essentially the Eastern Hemisphere, including Australasia, have done so well in suppressing or even eliminating COVID on a sustained basis that there is a lack of motivation that is different from the, say, anti-vaxxers movement in some places in the West, that people just don't see the imminent urgency to get vaccinated. And I think that you see that in some of the assumptions and some of the empirical data that Professor Cho has shown us. So I think it's extremely interesting, that presentation, and it really sort of tries to map the way forward, not only for Korea, but also really for the rest of the world, to show us how South Korea is thinking about the problem. And then we get a very interesting pair of presentations from Professor Zhong and from Professor Fisman. So I think both of them actually came at it to say, look, you know, the fundamental issue about infectious diseases, particularly those that are directly transmissible respiratory pathogens like COVID, is that you get this clinical iceberg phenomenon. You are not really seeing everything that's been happening. And in fact, you are seeing only a tiny bit of it. And so how do you then go and reconstruct these contact matrices or transmission matrices? And Professor Zhong was absolutely right in pointing out that, you know, in much of the world, there is not the so-called polymod experience that the European Union countries have actually spent a lot of time doing, led out of the London School and really coordinated there. So how do you then figure out, for example, who actually infects whom and to what extent? So I think that you get very interesting, but actually contrasting results from Professor Zhong and from Professor Fisman. And I think it's probably because of the data on which they respectively estimated those parameters, those age-specific transmission parameters. And I think that Professor Zhong probably maybe have used empirical observations from those pickup or detected cases in South Korea, and importantly, I think under PHSMs, so public health and social measures. And so those sort of empirical observations were picked up or detected when a lot of PHSMs were put in place and still are in place. But the fundamental question is, what if they're relaxed? What if they're changed? Then maybe you might see a completely different picture. So I think that one of the slides, the bar chart that's in 3D really was very striking, where you actually see a lot of the transmission going on between healthcare workers. Now we know that from SARS-1 or even MERS, that is indeed the case. There's a lot of nosocomial transmission. But I think this time, actually, we've done much better, you know, all around the world, where good hospital infection control and availability of PPE for, you know, a large part of the world have really shown us that the healthcare worker to healthcare worker or nosocomial infection in the hospital setting has not been a prominent feature. Instead, what we have seen a lot is perhaps in old age homes where you see a lot of nursing home outbreaks, and particularly David will be able to tell us about in Canada that's been a very, very prominent feature. And then you will, of course, also see that David had a very cleverly simple way of careful teasing out of the effect of testing strategies on what you actually see, and then backing into what really is going on, echoing actually what Mark Lipsitch wrote in The Lancet 10 years ago now, I think, in a piece he entitled How to Maintain Surveillance, in that case, and then was for H1 flu, when there are too many cases to count. So carefully teasing these things out and trying to distinguish, what is due to your testing strategy versus what is actually going on, using this series of SMRs and looking at the age-specific distribution of infection risk is extremely, extremely useful. Now, what I'm very intrigued by is why Quebec doesn't follow that particular clever inference. Maybe David can tell us about it later. And then finally, Professor Murray showed us the evolution, I think he said 5 stages in the IHME predictive model. So starting from essentially an extension of Farr's law, which went back, of course, to the Victorian era in England, all the way then using regressions to identify predictors, and then really then moving much more towards the SEIR transmission dynamics model. And, in those regressions, you see very, very interesting things about face mask use, and I suspect face mask use or compliance with face masks is also highly correlated with adherence to the other PHSMs. And just on face mask alone, it's very interesting because, again, it's something that is perhaps against public health dogma about airborne transmission, which even the WHO never really fully endorsed face mask use until last summer, 6 months into the pandemic. And that seasonality issue that Chris pointed to, again, looking at the flu experience, looking at RSV, certainly in temperate climate zones, seasonality has been a very prominent feature. But I don't think seasonality works uniformly across all climate zones, and where you get into trouble with seasonality is towards the equator. The closer you are to the equator, the less there is in terms of predictable seasonality. And then mobility, again, inferred in Chris's model from PHSM mandates, but I think several groups around the world, including our own, have shown that direct measurement of mobility may even work even better. And I think that work was really pioneered out of Africa by Caroline Buckey from the same group as Mark Lipsitch. And what I found very interesting in Chris's presentation was the infection detection rate. It sort of hovered around 0.4, which is extremely, extremely high. And I wonder whether that's universally observed. And I think it may be because of the seroprevalence assays, where, if you use ELISA, and even if you go and pick up the spike, there's a lot of cross-reaction with the 4 seasonal human coronaviruses, compared to if you use neutralization assays, then you will get a whole order of magnitude difference in the lab. And then I think that, again, border restrictions is something that nobody has really sort of been able to try to even make assumptions about, because it is so unpredictable with these travel vaccine passports. And I think that with more and more evidence coming out from the different vaccine developers about coverage for variants and then other new variants that may or may not be emerging, those are some of the frailties that we have to live with, however good our models are. So I think that I'm going to end there and thank the organizers and the presenters again for the privilege of being able to learn from and comment on their work. Over.
Thank you, Gabriel. I'd just like to remind each speaker and then discussant to stay where you are. We have this virtual audience over YouTube. So if you move, I think there might be some technical problem to lose you. So I just like to ask you to stay where you are during the rest of this section. So we have the next discussant, Professor Simon Johnson with MIT, and he's the Ronald Kurtz Professor of Entrepreneurship at the MIT Sloan School of Management. He also served as the former chief economist with IMF, International Monetary Fund. And his work has been widely cited, especially on economic and financial development across the world. So we are very pleased and privileged to have Simon with us and then to offer his insights and comments on these 4 presentations you heard so far. And then we are going to turn to the Q&A sections right after his discussion points. Simon?
Thank you very much, and thanks for the opportunity to learn from these wonderful presentations this evening in US time, this morning in Korea. I'm coming to you or just looking at this work as a practitioner, because in the age of COVID, I spent almost all my time helping to build testing systems for COVID testing for nursing homes, senior living, childcare, and a lot of work that we've put into K-12 school testing over the past 6 to 9 months, which I'll come back to. I'm an economist, as was just mentioned. I'm not a doctor or a public health specialist. So my job is to get money out of governments to pay for the things that you guys want. And in order to do that, I need to understand what you want and why you want it and why that's a good idea. And then we figure out what the cost benefit is and we go get the money. And there are 2 sides to that. And I think this is exactly something that David and Chris were both mentioning, which is, there's got to be a demand side and a supply side. So we need people who want to get tested and we need to provide the tests. And both sides of that are very important in this discussion. Now, I'm really thrilled always to learn from my South Korean colleagues, because there is so much to learn. And I'm always fascinated by the question of, is there something that South Korea has done or is doing now that we could adopt in the United States? Did we miss something? Was there a simple, straightforward approach, policy, a set of levers that we could have pulled and we failed to, and we, as a result, had a much bigger set of problems? So next time, or if Chris is right, in the time 3.5, whatever is coming to us, is there something we can do better? And I thought from Sung-Il Cho's paper, I learned a great deal about social distancing and thinking about social distancing. I also feel that it'd be very good to clarify that what you call social distancing in Korea is a much more nuanced, finely grained adjustments to social interactions than we have in the US. In the US, there are variations, obviously, but we have a lot of lockdown, don't go to school, try to do your school remotely, which doesn't work for poorer children, and so on. So if you're in level 2 right now in South Korea, which I have looked up, you can't, for example, go to a gym after 9 p.m. Okay, I understand that's a restriction, and I understand that may be burdensome, but 3 distinguished academics can sit next to each other on a panel, and I'm looking at them right now, not wearing masks. You can't do that in my country right now, not feeling comfortable about it. So that's a remarkable success that you've achieved in South Korea, and perhaps this idea of maintaining the social distancing until vaccination complete, if it's not onerous, what's the problem there? I think a little more explanation of that would have helped, that paper cross borders. I think it's also a very big question whether we in the United States could make that kind of social distancing work. I suspect not, but I'd be really interested to hear Sung-Il Cho's perspective on that, to see that reversed. I'm also puzzled by what appears to be a low rate of vaccination in South Korea so far. I would appreciate some discussion in the next section about why that is. Perhaps that's a lack of priority, perhaps it's a lack of access to the vaccine. There's a very nice chart in Sung-Ho Cho's paper on that. Yunuk Jung's paper I thought was really fascinating. I had not thought about optimal control vaccination strategy depending on R. I thought the mathematics were simply beautiful and really fascinating. But I'm also amazed and impressed, that you could possibly imagine communicating this to the Korean people and explaining to them that it's a good idea. In the United States, it's exactly what you said at the end, which is once you've got a policy, if you change that policy, you've got a lot of explaining to do. And if you change that policy again, forget it. It is a complete mess. It's a disaster. I will not tell you how many of my former friends have suddenly discovered medical diseases or conditions that bump them up in the vaccine line in the United States. The legitimacy of the process, I think is really important and a very important determinant. I think actually the whole issue of prioritization in the US was very poorly communicated, unfortunately, from the get-go for reasons we won't go into. And it's been so hard to unwind that. So I really like the idea that you could do optimal control on this. If you can fit that in your communication strategy, I'm all in favor. I just don't see that as something we could take into the modern United States or maybe many places other than South Korea. Now, of course, the big question that I'm grappling with and all my colleagues are grappling with on the East Coast of the United States is what next for COVID. And we do look to Canada for a better run version of the United States, David, I have to say, not to put a little bit of pressure on you. I really like the points about testing and about how, we have to communicate this to the policy people a lot, that who you test gives you this impression of what's going on with the disease. And I personally find the Ottawa picture to be pretty convincing, and I wouldn't be surprised if that's a much more general picture. We also learned, just like you did the hard way, that long-term care is the number one source of vulnerability. And we've also, I think, that this is the one part of the vaccination program in the US I would commend, is the long focus on nursing homes. I think it's actually been good. It's been effective. It was a federal program with CVS and Walgreens involved. And I think it gets high marks, at least the ones we've looked at closely. We have not, I think, David, done well in the US identifying other vulnerable people, right? So we always put them in the model. We say, okay, there are these people who are very old, they're in the nursing homes, they can't do anything to protect themselves. Then there's these other very old people, then there's other vulnerable people. That I think is a very big weakness of the US system. David, I'd be really interested to know how you've handled that in Canada, because it looked like from the various declines that maybe that's something you've done better with an integrated healthcare system, I would hope. And I think the British, who had a very bad first 9 months of the pandemic, actually did quite well on vaccination, because the National Health Service knows a lot about people, and people believe in the NHS. They believe that they're going to bring the vaccine to them at an appropriate time, and they changed that policy once. They extended the time between the first and second dose, but only once, and they got away with that, I think. So really interested to hear more about the Canadian perspective there. So I am always, like the rest of us, always reading Chris's work with great anxiety to think about what's coming. And also, Chris, to think about, in the policy space, what's the robust set of alternatives that we really have available to us that can, make sense to pursue, that we can get the money to support, and that makes sense in the various kinds of plausible scenarios that we may face. So the question for you is, and I'm sorry to pose this question, if this question upsets anyone, I really apologize, but I have to ask, are these the worst variants that we could imagine, Chris? I mean, are we done in terms of the emergence of variants? If you think, you tell me the epidemiological process and the immunological process behind the emergence of new variants, but is it possible there could be other variants still to come that are either more infectious or that have more immune escape, right? Because that seems to me to be just a question I have to ask you. The robust policy piece, but I'll put this to all four of the speakers and see their reaction. And this is to be clear, this is my prior. So there's a confirmation bias rampant at 9 o'clock in the evening. Sorry about that. Testing. So we spent a lot of time in Massachusetts. Mark Lipsitch has also, and his colleagues have also been fantastic leaders in this. Let me be very clear, and many other people in Massachusetts, building testing programs around nursing homes, other senior living, childcare. Well, okay, there's still a bit of a struggle there. We're working on that, but there's a big K-12 testing program now where all the kids going to school have the opportunity, and you can't mandate it, but it is a certain amount of, let's say, appropriate social pressure to test everybody going into a school building, everybody, and that's a million people every day. And we do it with pooled testing primarily, so that keeps the cost down, dramatic impact on cost. And this is consistent with the FDA's serial testing guidelines. Thank you, Mark, and your colleagues for changing those guidelines also, by the way. So now, of course, the question comes, now these programs are established, people are saying, hey, COVID's, okay, they were saying a week or 10 days ago, COVID's receded, why should we bother? That is not so much the topic this week, because we have variants present in Massachusetts, including Cape Cod has a lot of P1 now present. But still, I think what I take away from this from this is, look, I think we need to implement and continue to operate against what we've already put in place, which is, pretty good testing systems. These are lab-based PCR testing. We're all in favor of more rapid antigen testing at high frequency when it's commercially available, which it's not. We have Binax Now kits that are available and are effective, and we could talk about how those are used if anybody's interested. But I think it's test. And I think, Chris, that's what I take from your work, which is, if we're within this band, which is actually a pretty encouraging band for the US, testing costs me some money, but it's not a lot of money in the big picture. And it's an insurance against something going wrong, including, a really bad variant emerging very quickly. And that leads me to my last point, which is about the global conversation, the global policy interaction. And I think Gabriel and others will be leaders in this. So, again, I apologize for bringing this up now in March 2021, but I think in about 10 years, you might remember me saying this, which is after the financial crisis of 2008, there was a decade-long struggle internationally to build a safer financial system, and to do it in a way that didn't, negatively impact growth. It didn't hurt people. It wasn't about excluding people from the financial system. So 10 years of effort globally, right? Global financial system needs a global effort. Regulators and central banks and so on and so forth put a lot of time and effort into coordinating that. It doesn't take a lot in terms of fiscal resources. It's more a regulatory matter. I think we must surely be soon starting a process of international cooperation around pandemic prevention. I mean, maybe we can do better than pandemics, right? Maybe we can make it other natural disasters. Maybe we can include climate. I'm all in favor of that. But at least pandemics, it's been in our faces. It's a massive cost. It's absolutely horrible. And there are countries like Hong Kong, like places like Hong Kong and countries like South Korea that have shown there are better ways to manage the pandemic. Their ways may not work in other places. That's one thing we have to figure out. But what's the process we need to establish? What's the coordination we have to build? Who has to be and needs to be at that table? I think what you're facing here, guys, I'm sorry to say this, as something or a complete outsider from pre-COVID, I think this is what you're facing is much harder than what we had to face in finance and economics. Because in finance and economics, there were already structures. There was already a lot of agreement. There were very similar experiences in the global financial crisis. Some places were less affected, but everybody was affected. I think this pandemic is not seen in the same way everywhere, but we share vulnerabilities. We fear future recurrences, and I'm happy to help and encourage anyone who would like to learn from that previous experience and get this done in public health, because we do need you, and we need you to have money. Okay, I will get you the money. Let's put it that way. Tell me what you need, tell me what you're going to build, figure out who's going to put it together, and I will join the coalition of people who try really hard to get you the money, because I think we need you, all of you, everybody represented here, to be well resourced and to be plugged in together and really working seamlessly on this one. Thank you very much.
Thank you, Simon. I think we have very specific questions, and including some general questions from two distinguished discussants, as we heard so far. So we have about half an hour of the conversation, including some Q&As from the virtual audience. We may not have the time to cover all of them. I think the speakers also are eager to answer, respond to some of the comments and questions that this, two discussants have raised. So let's use our time well. So I'll give each speaker 2 minutes and to respond to some of the questions that these two discussants raised. I'm not going to repeat myself to paraphrase the questions that they mentioned. I think each of the presenter is smart enough. You know what they are asking about. So I'll leave up to each speaker to answer and then comment about the questions. So that's the how much time that you're going to have. And we're going to have perhaps another round. And then between those, and I'm going to have also some questions raised by my co-chair here, Professor Tae-Sung Park, and some other, I think, the questioners from the virtual audience. So with that kind of, I think, the order in mind, let me ask, perhaps the neighbor near to Simon. Simon is based in Cambridge, Massachusetts, and David is based in Toronto. So you are perhaps the close neighbors in the same continent. So let's go to David first. And then David, please respond to questions and comments by Simon and also Gabriel, based in Hong Kong.
Okay, I mean, Cambridge, it would take a long time to walk there, I will tell you that. So there are a lot of excellent points there. I agree in terms of testing. You can't fly blind. This is a complicated process. And if you don't have instruments in an airplane, you'll crash the airplane because you don't know how high you are or whether or not you're upside down. It's very similar in terms of understanding an epidemic, particularly an epidemic where a large fraction of transmissions come from individuals who either don't have symptoms yet or will never have symptoms, as Gabriel showed us last year. I think something that I have to add, I think you're exactly right on testing. I think one of the difficulties we've had in Canada is microbiologists have been stuck in a bit of a rut in terms of what testing is and what you do with it. And it's very much a clinical sort of paradigm where we test because we want to diagnose disease. But this is a very different situation. And I think there are at least 3 different ways you can use tests. You can use tests to diagnose disease. You can also use tests to hunt for the virus. We have a very successful region in Canada. The Atlantic region has been the equivalent of New Zealand. And their philosophy from the get-go, which they apparently got from the Icelandic folks who are not too far from them, was you go out and you hunt the virus. You don't wait. So, you use rapid tests, go find it. And then I think you have surveillance, which I liken surveillance testing to testing the chlorine in your swimming pool. You don't wait until the swimming pool is brown and has algae on the top to test for chlorine. You don't need to anymore, because you know there's no chlorine because there's stuff growing in the swimming pool. But what you actually want to do is when, at a time when you can't see anything abnormal, you want to be able to detect a signal that tells you that things are unsafe, or, as important, tells you it's all clear, continue, carry on. There's no problem here, people can continue. And I think particularly in schools, universities, long-term care facilities, hospitals, that's incredibly valuable, being able to give people peace of mind. I know I have only 2 minutes and I have a whole bunch of other points, so maybe I'll just wrap it up with this. One of the real successes in Canada, I think, is that a bunch of university labs that have been doing sewage-based testing have really come into their own. And I think we're starting to see sewage as an epidemiologic resource that extends well beyond COVID. It's had remarkable predictive validity in cities in Canada, on First Nations reserves, on remote First Nations reserves. And as my colleague Peter Uni here in Ontario says, it's the ultimate form of pooled testing, really. So we see signals ahead of time with sewage. And I think this has potential for future use for influenza surveillance. The Israelis already use it for polio surveillance. We can use it for antimicrobial resistance surveillance. As Frank Aristrup in Denmark says, you know, the entire tree of life is down in the sewer. And with genomics, we can understand our world in a very elegant way, notwithstanding that, you know, the distasteful nature of sewage itself. It's full of nucleic acid, and we can understand epidemiology differently. 2 very quick points. The economic question is something that was explicitly taken into account in the recommendations from our science table around how to vaccinate in Ontario. We have 90% of our cases coming from 10% of our postal codes, of our zip codes, and those are overwhelmingly low-income zip codes. So there was a strategy put forward to the government from the science table that said, vaccinate older people first, but start with the low-income zip codes. That is sort of the dominant strategy, and maybe we'll talk more about that. And Laura Rosella, my colleague, who's also on this call, was instrumental in those insights. The last thing I want to say is, and I'm sorry, I think I'm over 2 minutes, and I see Asaf has his microphone up, so maybe I'll leave it at that. But I would like to talk about the future and how we know whether we've learned from this experience. But I'll leave it at that. Sorry.
Okay, thank you, David. We're gonna come back to you in a few minutes. So I think hold your thought while we are going to listen to other speakers. So while we are in the same continent of America, let's go back to Chris. I think you heard quite a lot of questions actually by Simon. You know, when it comes to effect of vaccines and also the COVID variants on modeling, and then also pandemic itself, and then there are a lot of other, I think critical questions and comments. So I'd like to turn to Chris addressing those questions and comments. Chris?
Thank you. So let me start with a comment that Gabriel made, and it probably speaks to me not being very clear. But I think it's an important point. We've been including in the transmission, the predictors of transmission, the direct measurement of mobility since the last week of March last year. And we process each week 4 different producers of cell phone mobility data. So quite an elaborate effort. What's interesting is that when we now test adding on top of the direct measurements of mobility, the specific individual mandates, they improve model performance. They improve our ability to predict past transmission, and therefore hopefully improve our ability to predict the future as well. And I think part of that, there's just a lot to dig into, but for example, when we look at school closure mandates amongst the 25 that we track, above and beyond mobility, closure of schools, including primary schools, reduces transmission. And I think it's worth thinking about what that means, because what's happening when you're trying to analyze, you know, transmission in the past, you're not necessarily saying that opening schools is transmission amongst kids. That certainly occurs, but it's all the other behaviors that go along with schools being open. And so I think it's quite a bit more of a complicated, nuanced thing. It is, we get demands from many governments, particularly in Latin America and Europe and in the US, for advice as they think about coming out of stronger lockdown, which mandates to keep in place. And I think that's there'll be some useful insights from that for that really challenging discussion. Second observation on have we seen the worst of the variants? You know, I'm probably not the right person to ask, but you know, even if you track what's happening right now, there's the idea that P3 in the Philippines is a worse form of P1 with greater escape. Of course, we don't have trials. We don't have direct measurements. This is, you know, somewhere in that zone of looking at things that look like the EEC mutation and, you know, what that does to transmission. I would hazard a guess based on the immunologists that I talked to that we have not seen the worst of the variants. And I think there was that interesting paper in Nature of a poll of immunologists, 90% of whom thought that, you know, COVID was here to stay, that despite vaccines, that we will see COVID transmission in the long term. Although it didn't exactly come up in the questions, I think Gabriel alluded to this issue around herd immunity. I think if you, in a world without escape variants, you know, at some point, even if herd immunity is going to change, the level required in different communities based on the intensity of transmission, it might change by season. Nevertheless, there'll be some point at which you would say transmission will stop. In the presence of escape variants, that's not obviously the case, right? You need to rethink the whole construct of herd immunity. It becomes variant specific, you know, non-escape versus escape. And, you know, maybe with boosters and, you know, the vaccine staying ahead of the variants, the issue of escape variants, you know, we'll put behind us. But I don't think that there's any prospect of that in the next, you know, 9 to 12 months. That's probably farther out. You know, I think we probably haven't spent enough time talking about the escape variant implications, but Simon certainly was getting at that critical question. I think that will be the predominant question. It is right now in Europe and the US, of course, but will spread elsewhere as well.
Okay, thank you, Chris. Now, I think let's come back to the Asian continent, where I'm speaking at the moment. So we have lady and gentlemen here. So let me turn to Unok to address some questions and comments that you heard from two discussants. Unok, please.
Thank you so much for good comments, Gabriel and Simon. Thank you. Well, in our vaccination work, there are two key points. The one is constructing transmission metrics without survey. So this is quite, interesting for me because there is no data for contact metrics in most of countries, right? And it takes actually so much time to do survey, but you have now, you know, the patient data. So you might use, the similar method I used to construct content matrix. Then, because every country has different COVID-19 policy and the culture, right? Economic situation. So I think the data might be so different. So which means contact pattern is so totally different, even though we have same COVID-19, right? So constructing the contact metrics using, mathematical method is quite interesting for me. And the other one is Simon said, inform the research, the vaccination priority, the research to government people. And actually I did, because this work has been done, supported by KCDC. And they are very interesting in the research. This is not published yet, but I'm happy to share our research with you guys. And I was also surprised. The research is very sensitive to change the reproductive number. So, but you know, it's hard to change the government policy, even though reproductive number is getting increased, right? So I suggest them it's really important to keep reproductive number low, which means we have to do vaccination policy. At the same time, we have to do also enhanced social distancing. So, yeah.
Okay.
Thank you so much for your comments.
Okay, thank you, Unok. So let's turn to a gentleman here sitting with us, the Sung-il with SNU, and please, respond to questions and comments you heard.
Thank you very much. I really appreciate your very, very insightful comments and perspectives, also questions. There are a lot of issues, but I'd like to select a few important issues to keep the time. First, Professor Long's comment on herd immunity issue. We also, academic community in Korea also tries to avoid this H word anymore. This is somehow misleading, especially for many people, for public, while the vaccination rolling out is going on. So it may provide a false hope of impossible ideal. So these days, government don't use this word anymore, and academic community tries to avoid this word. But the mechanism of herd immunity slips in during the simulation process. So it's an ideal tool to process the modeling, not a real target. And also, I think it's extremely important to think of the cluster property of the transmission network. And we had an experience of very large epidemic because of the hidden large network. And now we are moving into a stage with fewer, from fewer large network to the smaller, more numerous networks spread around the country. That creates a higher baseline than before. So the current social distance strategy, I now move to the social distancing issue with a comment by Professor Johnson. And Korean government has been trying to develop adaptive strategy considering the level of the daily instance. So there are a number of changes over time. Now, Korean government has developed a four stage. It was originally 5 stage. Now, planning 4 stage simplified model, usually based on 2 strategies. First, facility-based strategy regulation, and the group size-based regulation. And facility-based regulation also involve time of the opening of the shops, restaurants, and so on. So in some way, it can be fairly complicated, but what the government tries to do is classify the type of facilities, but of course the type of facilities can be, the classification can be very crude, and there are many complaints about the coarse classification without adjusting to the individual places. So, but that's a very, very difficult challenge. So there are diversified approaches to keep the transmission or contact rate low. And one last issue about vaccination speed. In some way, the early slowness of the vaccinations rollout was in fact planned, because the government and many experts agreed that we don't have to take the risk of too fast vaccination, because we thought that the cost of waiting, as I mentioned before, cost of waiting is tolerable in Korea, considering the uncertainties initially. But now, in retrospect, we always have some regrets whenever something turns out. So we sometimes wish that we should have done it faster, but now the rate of facilities, rate of infrastructure, the strengthening the infrastructure and providing the supply network may take some time to keep the speed under limit. But also there is another issue of public health personnel. The same public health personnel also need to handle testing, tracing, and the social distancing regulation, as well as handling the vaccination rollout. So we have certain balance in the distribution of the resources. Thank you very much for the comment.
Okay, thank you, Sung-il. We have a few questions actually from the virtual audience. Let me just make sure that I'm reading them right. Actually, one of the questions has been already answered. You know, if one of the questions was actually if the inoculation has anything to do with this, modeling outcomes. Actually, we have 2 papers and actually 3 papers addressing this question. So we don't have to discuss this question in particular. But there is one question. This is about also the question about variant of the COVID-19. What if the more serious variant of the COVID-19 come out, and if it's not going to actually, be well treated by the current vaccines? How do you handle such a perhaps the potential crisis? This is not an easy question, but actually this is one of the points perhaps the commentators has also pointed out. So could any of the speakers respond to this question from the virtual audience? David, Chris, David?
Sure. I mean,
yeah.
I think that if you look at the WHO's priority list of things we don't have vaccines for but need vaccines for, I think they're either all or almost all RNA viruses that emerge at the human-animal interface. So the sorts of things that create this kind of risk for humans are actually fairly stereotyped in that respect. Why RNA viruses? Why not DNA viruses? Well, RNA viruses have the capacity to mutate and change very quickly. Some, like influenza, mutate very rapidly. COVID doesn't drift as fast as flu does. But I think what you see is the inevitable result of passage through a lot of human beings. If we have a microbe that has infidelity in terms of how much the progeny look like the parent virus, what we're going to have is a lot of genetic diversity. So the virus, what we see around the world, is convergent evolution, where mutations that confer advantage on the virus become dominant and emerge. And, this isn't something that's COVID specific. This is why we have an influenza season every year. This is what RNA viruses do. And I think what you have to look at is, what's our solution with influenza? We change the vaccine. So it sort of becomes a little bit of not a game of chess. I don't want to anthropomorphize the virus to that extent, but it's a game that we are playing where we are having to respond and the virus responds. There seems to be some magical thinking around this pandemic that a light switch is going to turn, be flipped at some point, and the WHO is going to have a press conference and, pull up a curtain or, something like that, or pull a sheet off a statue and say the pandemic is over. It's not going to happen that way, just as it didn't happen in 1918, 1919. What happened when you look at Chris's graph, what you actually see are pictures that look a lot like 1918, 1919 in terms of the seasons, in terms of the hemispheres, in terms of a third wave in spring of 1919, followed by a fourth wave in autumn of 1919, and then nothing in a mild flu season, I believe, in 1920, and then a terrible flu season in 1921, which was called a flu season, but was really the fifth wave of the pandemic. And at some point in the 1920s, this kind of evolved from being a pandemic into seasonal influenza via increasing population level immune experience. And I think that's our likely destiny. We're probably going to speed that process up because we're lucky enough to have vaccines, although access to them is going to be inequitable. But I think we have to anticipate that as we become immune to certain lineages of the virus, that confers a selective advantage on viruses that have mutations that allow workarounds for that immunity.
Okay, thank you, David. Let me ask also Gabrielle, if you have any insights to address this question of the potentially serious, I think the variant of the COVID-19 and how we need to be prepared. Based on I think the experience as a in medicine and then your experience in WHO, perhaps you can share your good insights with this virtual audience and many other people.
Right.
Gabrielle?
I don't think that we're done with variants yet. And variants, it's really just part of evolution. What we've seen with the 3 or 4 variants of concern that are talked about the most, the B117, the B1351, the P1 and the P2, I think what you can see is that at least a couple of them actually popped up in different places at the same time, which points to the idea of convergent evolution. And secondly, I don't think that we are done with variants of interest, at least, and possibly variants of concern. So variants of interest are simply, variants that you pick up on routine surveillance that might have the potential for either spreading more easily or causing more serious morbidity or mortality. And then variants of concern is the next step up, that they have actually been shown to either have higher transmissibility or greater severity. And I think that, what we are going to have to live with is that SARS-CoV-2 is going to be with us, that is being endemic, for quite a little while. And in fact, many people, and one of the first to have sort of said that and systematically quantified those probabilities was Mark Lipsitch and his group in a paper in Science 9 months ago now. So I think that what we're looking at is not SARS-1 or MERS. You cannot drive it back into the wild. What you need to do is to think about it, not exactly using flu as an analogy, because this is not flu and flu is not COVID, but really rather to think, look, how do we get on with life such that at the minimum we suppress and mitigate such that we do not have unacceptable excess morbidity and mortality. We will have excess morbidity and mortality just as we have for flu every year, but that it's not unmanageable beyond a winter surge or seasonal surge that stretches but does not make our health systems collapse. And I think that what we really need to do is to try and find an equilibrium set of interventions, whether they are pharmaceutical in nature, that is vaccines and better treatments, or they are public health and social measures, or most likely a combination of all of the above. And that's really the way forward. But I think as far as variants are concerned, specific to your question, surveillance is the biggest bottleneck and challenge that we need to rise up to. Because if you actually look at surveillance infrastructure, many of us are far from the ideal. And even if we are doing well now, under a pandemic situation, can we keep that up as sort of a normal routine? So I think that there is a lot there that we still need to think through. And then, of course, about sharing of these samples, or at least the results of these sequences in a real-time and open manner. Because, from the WHO flu experience with PIP, or the pandemic influenza framework, it's not a straightforward matter, especially when it comes to intellectual property and then access to vaccines. Over.
Thank you, Gabriel. We are running behind the schedule, but let me just ask my co-chair, Tae-sung, to ask a very short question in 30 seconds, and then I think I'm going to ask some of the speakers to respond in a very short time span. Tae-sung, you have a question to...
Time to?
Yeah, just very short question.
Okay, Professor Jung, Unok Jung, I'm wondering, you defined 4 different groups, but group 1 is only for the house care workers, and the other groups are based on the ages. So I'm wondering what would be the justification for the grouping. And another quick question to David, is I don't like the term like the heterogeneous and variability in data analysis, right? So I think in your modeling there are a lot of variability. So I'm wondering, do you have any special strategy to handling those kind of high variability and high heterogeneity in your approach?
Okay, stop there.
Stop.
Those two questions are good enough to perhaps the address. Unok, would you make your response very short?
Yeah, in the beginning of vaccine priority strategy, it's we need healthcare workers, right? So we just consider healthcare workers, and then divided the ages. So this is, I think, a reasonable approach from beginning of vaccination. But we can do also the age specified the group vaccination modeling. But I think this is good start for beginning of vaccination strategy.
You two have some offline conversation later on. Let's turn to David to answer Taesung's question.
I wasn't sure that I totally understood the question, but it related to how we've dealt with heterogeneity when there is so much scatter over time in risk of disease. That would be fair? So I glossed over this, but what we actually did in terms of those models is they're not regression models per se, they're meta-regression models. So we've treated each week of the pandemic as an individual stratum, and we're using meta-regression, so it becomes a framework where we can actually capture the variability within each stratum and incorporate that into the model, and we downweight sort of very uncertain high variance strata where you have very few cases or very few tests, and we upweight the more the more stable, more precise estimates. So it's actually a meta-regression model rather than a regression model.
Okay, thank you, David. I actually used the coffee break time that I think we are supposed to have. So it is on behalf of the virtual audience with us. So I hope not many people mind about this changing schedule. But before I turn to the section 2, again, I'd like to say to each of you, presenter and the discussant, joining us with this virtual audience across a few continents, and we'll get back perhaps soon together, and then perhaps talk about some of the critical issues. But again, I'm so grateful to all of you from the bottom of my heart for joining this conversation. So thank you again, and we'll meet again next time. So we are going to have next section in 8 minutes. Okay, we are going to have next section in 8 minutes. That means I think the 11:05. So this is for the virtual audience. We are going to start next section entitled Science-Based Policymaking, Lessons Defining Readiness for a New Normal. And we are going to have distinguished speakers from Harvard, University of Toronto, and also the CIFA, and then Korea CDC agency. So please join us for the next section in the next few minutes. Thank you all again.
welcome back to our session. Now let's time to start our session 2. The title of session 2 is about science-based policymaking lessons defining readiness for new normal. In this session, we have 4 speakers. 2 are from the Korea and 2 from the North America, and we have 2 discussants. Okay, our first speaker is Dr. Young-Jun. He is currently working at the Director General of Statistics Research Institute and Statistics in Korea. Originally, he has worked on the sociology and then survey sample. Now he's working on epidemiology right now. So today he's going to talking about pandemic forecasting and nudging science-based policymaking. Dr. Jun.
Thank you, Taesung. I'm very honored to speak in this international symposium hosted by Korean Academy of Science and Technology, National Research Council, and Statistics Research Institute. And this is such a, I think, a great joint effort by these 3 parties. This morning, this afternoon, this evening, depending on where you are, I'm going to discuss this pandemic forecasting and nudging science-based policymaking. I'm going to actually go over sort of genesis and progress in prediction science in the case of Korea. And I have my co-authors and then also other people working together with me acknowledged in the next slide. And I'm going to skip quite a few slides very, I think, quickly, and then I'm going to focus on just a few slides for key points to discuss with you. So basically, I'm going to talk about why science-based policymaking in Korea. And I'm going to talk about phase 1 to 3, from genesis to evolution to revolution of the AI-based innovation and digital economy in a new normal eventually. I think I just like to tell you that this science-based policymaking has been, I think, initially started in the Blair government back in 1997, and they call evidence-based policymaking. And this was very important start, I think, across the world. And then in Korea, back in 2007, President Roh Moo-hyun and his government established the system of evidence-based policymaking. So government decisions can be based on data and then science in a lot of, I think, the other sectors, and then also some cross the sectional the fields. Recently, as recent as 2014, United States has also started this evidence-based policy-making commission, and then they institutionalized this kind of system across the government. So they do have pretty, I think, the wide evidence-based policymaking across the country. That's the kind of foundation of how science-based policymaking has come about in Korea, United States, and the UK. Just like to tell you about this sort of Canada and then Korea science partnership that we started in the wake of the COVID-19 back in spring of the 2020. So we started this partnership between University of Toronto and Statistics Research Institute of Korea. So we can help together to stem this COVID-19 on scientific ground. And Prime Minister, who delivered congratulatory remarks today, actually talked with Deputy Prime Minister Chrystia Freeland of Canada for collaboration over a year ago over this issue of the COVID-19. And that was the very good starting point of the collaboration across the continent. I'll just talk about some foundations of this data science practice to stem a global crisis we call COVID-19 pandemic. And I'll go over why it is critical to understand this reproduction number, RT, why we actually used this so-called idea that is based on SIR model, very classic model of epidemiology. And then I'm going to talk about this evidence-based response to STEM crisis using a few modeling outcomes that we have put together in the past 12 months in the case of Korea. So most of you, I think they must be very familiar with this notion of how the RT has been coming about in terms of the P, C, and D. probability of infection, that is standing for the P, and contact propensity with the infected, that is the C, and the D is the duration of the spread by the infected. We know this by formula, but when it comes to public policy making, we got to have some kind of mechanisms that is very parallel to each of these factors that is affecting this reproduction number. So when it comes to probability of infection, in the case of Korea, we have a lot of these personal level measures, including using wearing mask, hand washing, and also using a lot of these hygienes in public places. In response to this contact propensity with the infected, we have also a lot of these measures of the social distancing we heard from the section 1, and also a lot of other societal level non-pharmaceutical interventions that include virtual education, teleworking, and also preventing mass gatherings. So this C factor is very critical, and then social distancing and many other non-pharmaceutical interventions are very important response to controlling this C factor. And then D, this is the duration of the spread by the infected. This is where Korean government has been doing pretty good job in terms of the 3T system. Testing kit, and also we have this ICT-based tracing mechanism. And lastly, we have treating system. Even when you do not have the medicines to treat them, we have some mechanisms to handle the patients in isolated places. So we have so-called 3D system. So each of these mechanisms is very important to handle each of those 3 factors. That is the foundation to controlling this R. I'm not gonna go over all these technical details of the methodology behind this method of the incidence decay and exponential adjustment. That is actually proposed by David Fishman. You heard from the section 1. So this is the paper that he put together, and then explaining the details of this idea methodology. And in principle, in the case of Korea, we have used so-called dynamic distancing. The concept itself is very straightforward. If you do not have this social distancing and other non-pharmaceutical interventions in place, we are going to have pretty high level of the infection and mortality rate. But if you use this social distancing in a very dynamic way, so keeping the balance between social distancing and then other measures, and we can actually flatten this pandemic curve at the level we desire. And paradox of the prevention is that the more you control it, actually the more cases that you still have in the population. So this is not an easy issue, but we like to control it at a certain level, and then while we have some other mechanisms to exit out. And that's where the vaccines come in to play. And so that's the kind of pattern that you see here in this paper. And that's the kind of principle of that dynamic distancing Korea has used in the past 12 months. And I think the important part of the this SIR-based modeling that we have implemented in the case of Korea, I think has a few factors that I just to describe. Evidence modeling, epidemic modeling is a science and art. A lot of people call this science, but we also have this art components, because we have to tailor this scientific methodology to different situations in different countries across different contexts. So that's why I call it sort of art component of this epidemic modeling. And the main focus of this modeling is to reduce uncertainty in the future. We have a lot of factors to influence the outcome I think that we desire. And so eventually, we like to reduce the uncertainty as much as we can. So we have so-called neo-casting and evidence-based policy making in place. And in the case of Korea, we have this legal infrastructure we put in place since MERS outbreak in 2015. So we could have a lot of this transparent contact tracing supported by the IDCP Act passed in the Korean National Assembly. This is very important legal foundation we institutionalized many years ago, and that was the principle we have used in I think the defense of this current COVID-19 pandemic. So let's demonstrate a few model outcomes that we have put together in the past 12 months to illustrate, I think, the merits and challenges that we had in Korea. This is the model based on IDEA. We have actually put together in partnership with David Fishman's team back in March of 2020. So we have initially predicted apex in early March and lowest level in early April, and then we forecasted about 11,000 patients by the end of May. What was the outcome after this the prediction model? Actually, the outcome of the pattern of this COVID-19 epidemic in Korea was pretty consistent with what we predicted using this IDEA model. So the nation was able to actually be better prepared, knowing what's going to happen and what is the this high point of this COVID-19, how soon we are going to have actually low point of this pandemic. So this was very important start for the whole country. And government decision makers actually have used this methodology and then outcomes as a kind of guideline to plan for important policy makings in education, public health, and many other fields. And I'm going to show you some other related, I think, the modeling outcomes. And we also try to measure this R, as I told you about in the beginning of my presentation, and why it is important to measure R, and then we like to see how it has reduced in certain period. This is the one example that we have actually demonstrated, back in January to March of last year, and how R has been declining over time. And also, we actually did some local prediction of the IDEA model, especially in the southern province of Korea, when we had this very serious outbreak in so-called Daegu and Gyeongbuk region. So again, we applied it, and we actually came up with pretty good model outcomes. Eventual outcome of the spread of this pandemic was very consistent with what we modeled. So this model was very useful to make important decisions back in I think the spring of 2020. Okay, another thing that we actually try to see is that what is the estimate cases that we could prevent in the case of Korea back in April 2020. This is the based on the estimate David Fishman put together and we shared widely back in spring of 2020. Actually, we estimate about 3.4 million infections could be prevented because of this social distancing, other MPI interventions that we have created. This was very important information that we had, back in spring of last year. And so we can see the impact of, a lot of important social interventions and then other measures that public has in compliance with. I'm going to skip many of these remaining modeling outcomes just to show you how many more modelings that we have done. We try to communicate with policymakers and make sure that they also follow some of the key recommendations that we have put together in terms of how soon we can relax or also making it more strict in terms of social distancing the level. And so we have done a lot of those recommendations together in terms of the collective insights. I think the scholars and researchers of modeling put together in the next several months. So I'm going to skip many of them. This is the modeling 6. Eventually, we have done about 25 modelings in the 12-month period in last year up to last March. Just to show you what we have done. And then one thing that we try to also, I think, reflect in this modeling effort is that how can we confirm if the people are actually in compliance with the social distance measures. So we had this big data analysis using the data from this, the telecommunication, the company, and then we have about 20 million sort of mobile users and put their data together to understand how mobility has changed over time. this was very critical, I think, the component and then data we actually used to ensure that we are actually going in the right pace. And people are actually in compliance with social distance measures mandated by the government. Sometimes this was not necessarily follow the pattern that government expected. And then government has changed some social distancing measures, knowing what change that actually public has made. So this kind of big data analysis was very important. And I heard this morning from Section 1, I think the US and Canada have done similar kind of measurement to understand how the mobility has changed over time. And then we turn to this phase 2 of the adaptive strategy. And this is where I think that we have done a lot of different variants of the modeling, including SIR, SEIR model, SEIQL model, data simulation, and segmented Poisson model with policy variables. And we had this collective insights of the multiple models of the SIR-based variants. And this was very important ground for policy making in the next several months. And I'm going to skip many of them. Just to show you, what we have done in terms of collective insights, how different scholars working together, and we have jointly put together these insights, and then government has made a decision based on these collective insights. And this is just illustration of those modeling the outcomes. And let me conclude my presentation suggesting we have these next steps we need to think about, so-called AI-based innovation in digital economy. I know we are going to hear from some of the speakers about this AI-based modeling itself, so I don't have to spend my time on it. But I just like to say one last point. We need to continue to having these evidence-based policymakers in place. Even when you have very good modeling outcomes, if you do not have the policymakers who listen to this public, I think the modeling the outcomes, there is no use of it. So that is very important. And then we also need to have the blue data designers. I call blue data designers because we need to have the data lake, data mountain, and data ocean all putting together as a blue data. I think the very rigorous data we can put together and then use them as a kind of input data for AI-based modeling. And eventually, we can use those blue data as a kind of AI-based, I think, data modeling for pandemic. So that is my last, I think, the point of my presentation. Just like to leave you with this painting by, Miro, and then I'll get back to it later. And then this is the Sears, and then he had this, vision of the painting, but we have this data science as a tool to predict the future. So I think we can use the imagination, but we have this hard evidence to play with. And so that's my, I think, the conclusion. Thank you.
All right, thank you for the nice talk. Let's move to the next speaker.
Next speaker, Tae-sung Park. He is the professor of statistics at the Seoul National University, and he has done a lot of stat-based and biostat-based work, and his work has been quite, I think, widely, I think, decided. So we are very pleased to have him to talk about his work on prediction modeling, especially from traditional statistics and AI. So, Tae-sung.
In my talk, I will talk about two things. One is national factors, and the other is government policies. Okay, what is the national factors? It's like such as GDP, total population, and medical infrastructures. Okay, I'm interested in pointing out what kind of these factors going to be influence on the spread of COVID-19. So using the growth curve models, we're going to evaluate the effect of those national factors. And secondly, we're going to consider about many different government policies like the school closing and workplace closing. There are many different policies have been implemented by each government. And I'd like to evaluate which government policy has been effective in reducing the rate of spread of COVID-19. So I'm going to use the trajectory analysis for this kind of analysis. Okay, I think as you know, there are a lot of public data would be available for COVID-19 in the worldwide. Like we have more than 125 million confirmed cases. And now there's a lot of public data would be available to showing different patterns across the countries in terms of the cumulative confirmed cases and also cumulative deaths. And also we have some talks about the test, right? COVID-19 test run per 100 people. Every country provide different information and they are doing every effort, right? But now there's a lot of report about the vaccine policies and also the containment and the closure policy have been implemented since the beginning of the outbreak. And also a lot of policies about healthcare and medical systems, and also some financial support. Okay, I'm wondering what kind of this kind of policies would be effective in controlling the spread of COVID-19. So that's my fundamental question. And this is a stringent index of 150 countries. Okay, the darker color means the more stringent, and less color means mild stringent. Okay, so for example, in the Canada, they're doing very good, using very strong stringent, and then United States is okay, and Korea is a little bit mild. We are in the middle here, right? Okay, so the question is which national factors influence the spread of COVID-19? And here, national factors means GDP and total population. Those are factors that distinguish between developed countries and undeveloped countries. So we're going to use growth curve analysis. And second question is, many countries have implemented different policies. And I'm wondering which policies would be more efficient in controlling this COVID-19 spread, such as like school closing and income support and workplace closing and so forth. Okay, we're going to use the COVID-19 data sets. We use the daily confirmed cases provided by the ECDC website, and also the government policies have been open every day by Oxford University. So we're going to use that kind of data set. If we look at that data in detail, like every day daily confirmed cases have been reported for each country in here. And also the government policies have been reported for each country and every different date. Like for example, school closing and workplace closing. It has values from 1, 2, 3, 4. So it has some ordinal information. And these are detailed information, like the first part would be some closing and containment variables here. And this is some like economic support variables. And these are the health-related policies. Recently, like facial covering and vaccination policy, and those are newly added. And these are some summary measures. So we performed two analyses. One is the first is growth curve analysis. Okay, let me give you a brief idea about the growth curve analysis. We do have daily confirmed cases like for the Korea and for the Canada here. And they shows this kind of S-shaped growth curve patterns. So for each country, for the given data set, we're going to fit these growth curve models, and we're going to summarize a long series of data into like 3 parameters. And then we're going to perform some like regression type analysis to figure out what kind of national factors is going to be most effective. Okay, and we use the national factors provided courses by the Korean statistics, like 5 courses, like some trades and environment and national account, and some like education and health variables are available. And also we used another source, our World-in data, like they provide a similar information here. Okay, and we fit the three actually the cross-code models, but the Butterland fit is very difficult to fit, so we only report the results on logistic and comfort model here. For the given data set, they always have this kind of S shape, right? So if we fit the cross model, the model usually contains three parameters. One is the one which represents when does the peak start and how fast the peak going to be reached, and what would be the maximum values here. So we have the three parameters, point here and increase rate and the maximum points. Those are three parameters, okay? And also what we considered is about segmentation and moving average. This is the recent Korean data set here. So we have some peak by Daegu and another peak by Itaewon, and we have the suffering from third peak, right? So the first part is called first segment, and second part, second segment, and third segment would have different patterns. So we allow different parameters. That's the segmentation model. And each day have a lot of variability. So instead of using daily based data, we're going to use some moving average. So we use those kind of ideas in here. So let me show you our cross-curve analysis. Actually, we performed two analyses. One is the first freeze data until August 30th last year. And then we used some update data until the end of the last year. Okay, and for about more than 200 countries, we apply some segmentation criteria and then fit the cross-curve models. And some models provide a very poor fit, so we delete them, and only we used the one which provide the reasonable data here, about 100 and about 10 countries. Okay, based on this result, we look at the p-values of the coefficient for the national factors. So the first is the parameter for the first part here, and they have very significant effect here. But this is about the total population. And for the other factors, we have some significant factors. Those are the like p-values, and for wave 1 and wave 2. And also for different regression models for the logistic and compression models, they provide very consistent results. For the first parameter, the total population perform pretty well, and we do have very consistent patterns for some selected national factors here. Okay, and these are the coefficient significance. Some have positive values, some have negative values in terms of the rate of gamma. And for those models, two models provide very consistent results. Okay, so this is the summary for our analysis. We fit the model logistic and segment 1 and logistic model segment 2. And we fit the compression model using segment 1 and compression model segment 2, right? As you can see here, we identified very significant national factors. Among them, as you can see here, the factors related with age, they turn out to be very significant. Okay, and also we performed the second freeze data set using more number of countries and some longer duration here. We followed the same procedure in our analysis. And this is the results for the second freeze data set. I think I do have the graph for the first freeze, but anyway. So this is the plot for two parameters obtained from the cross-curve models. So the alpha represents the total number of confirmed cases, okay, and the pick point, and gamma represents the rate of speed of increasement, right? So as you can see, some countries like the United States and India and Brazil, they have very large number of confirmed cases, okay. But on the other hand, like if you see the New Zealand, they have a small number of confirmed cases. But if gamma is large, that means they have the high slope of increase. So in other words, New Zealand have the small number of confirmed cases, but they have a relatively rapid slope. So this kind of interpretation can be made using based on the cross-curve parameters. And for the second freeze data set, we performed a similar analysis. And in this analysis, like some factors such as malnutrition population and total fertility rate and extreme poverty turn out to be very important factors to determine the spread rate of COVID-19. Okay, and second analysis is trajectory analysis. The main purpose for trajectory analysis is to evaluate the policies, right? So we're going to use the same number of confirmed cases here, right? But for the policies, the countries change their policy every month or every 2 weeks, something like that, right? So those policies are time variant covered. So as you can see here, this peak represents the overall confirmed cases, but this is going to represent the policy, specific policies. So according to the calendar times, they have different policy changes here. We like to know which policy have the largest impact on the COVID-19 confirmed cases. So through statistical analysis, we like to get the p-values for each policies. So that's the purpose for our analysis. You know, to handle those kind of analysis, all the data are serially correlated, right? So we used a statistical model called generalized estimating equation approach. And we model in terms of the total number of confirmed cases. And T and log T is included as adjusting covariate. And then we include every policies, right, as beta terms. And then we evaluate its significance. And as you can see, if we start one policy right now, but the effect is going to be appear later, maybe 1 day later, 2 days later, or maybe 1 week later, right? So our model allows that kind of lagging effect. And for the given the data set, when we analyze the first freeze at the end of the August last year, we focused about 90 countries. So when we look at those 90 countries, there are some countries with only 1 wave, some countries with 2 waves, some countries have even 3 waves, right? So we grouped those countries into 3 groups, and then we performed subgroup analysis. And also, first wave, second wave may have different policy effect. So we also performed wave-specific analysis using our models here. So this is the result. Okay, for all 90 countries in global, this one represent the coefficient. So this is positive effect, and this represents negative effect. Okay, and this is the minus log p-values. If the value is high, that means that is very low p-values. In other words, it has very significant effect, right? So the policies in here, they turn out to be very significant effect here. So like some containment policies and some health-related policies, they have very strong effect here. But on the other hand, if you look at the E, this is the economic, like financial support-related policies, they have much low effect and is also non-significant. And those patterns are very similar if we perform like group-wise analysis, group 1 and group 2 and group 3. They are very consistent patterns here. And even though we perform the wave-specific analysis, we also identify some significant factors here, like some containment, stringent index, they have very consistent effects. And as the time lag increases, the effect is going to be from positive side to the negative side. So we do have very consistent patterns from this analysis here. So this is the results for the second wave. And this is a summary of our analysis, like the group 1, group 2, group 3 wave analysis. So this kind of crossing policies are very effective. And if we perform the wave-specific analysis, also the stringent index and some school crossing turn out to be very significant effectors here. And we also performed the second freeze data and third freeze data, but I mean, this seems to be much more complex, and we are still struggling to summarize the data. The reason is that if we extended the day here, then we'd have a lot of countries with more than 3 waves, 4 waves, 5 waves, even 6 waves. So it's very challenging to analyze that kind of data set. And we performed a similar analysis here, but I don't have time to show you the results. But the pattern is similar, but it's much more complex, and the effect is going to be much more reduced compared to our first wave. Okay, but still we got very consistent results. Okay, so still we got very important results for the crossing variables here. And this is the last part for the third wave freeze data, and we are actually using the whole data till the last week using 186 countries. The model is much more complex here, right? And we performed similar analysis, and we got very consistent results here. But the effect what I like to point out is we have some vaccine effect here, denoted here like H7 here, right? So at first it has some positive effect, but it turns out to be negative effect, and it has very significant effect, okay, so as we expected. Okay, let me conclude my talk. So we performed the gross cover analysis to evaluate the effect of national factors, and some population turns out to be very significant, and also in our first analysis, age-related factors are very significant, and we're going to perform this analysis for more extended date. And I think this approach can be also applicable to the number of death cases. And for the trajectory analysis, we identified many different policies, but still, contact tracing and health index are most important factors. Okay. And for further analysis, we can extend these models to extend the data, and we are actually working on extending different models. So far, we focus about segmented person model, but other like the non-linear regression and like deep learning model can be applicable. So we are working on that part too. And finally, I'd like to just point out that our model is different from the other previous models, other previous speakers presented. They are mainly based on the ordinary differential equation models. So they focus about the prediction, and then they use simulations to some making predictions. But our approach is statistics-based, and our approach is like a macro-level analysis, right? Focus on the analysis difference between countries, and also we evaluate for the given data set as they are covered. Okay. So this is data-driven analysis. Okay, I'd like to acknowledge to my students for their contribution. Okay, and we have worked on the many different topics for COVID-19, like our group worked on antibody retention rate and some government implementation, and we also worked some forecasting, and also we worked on the clinical data analysis, so we developed some nomogram for predicting the clinical severity for the COVID-19 patient. Okay, I will stop here. Thank you.
Okay, thank you, Tae-sung. Just like to tell you, you are in the middle of a second section entitled Science-Based Policymaking, Lessons Defining Readiness for a New Normal. So we just had two speakers. Now we are going to turn to the third speaker, Professor Mark Lipset with Harvard School of Public Health. And he's also leading the Center for Communicable Disease Dynamics. And he's an elected member of the U.S. National Academy of Medicine. So we are very pleased and honored to have Professor Lipset with us and to speak about this paper entitled Accounting for Uncertainties in Prediction When Making Vaccine Policy. Mark? Mark.
Yes, is that good? Can you hear me okay?
Yes.
Okay. Well, thank you to the organizers and to the audience for this opportunity. It's really an honor to be in such excellent company and speaking to you late in my night and in your day. I've very much enjoyed what I've heard so far and look forward to this discussion as well. I want to talk about accounting for uncertainties in predictions when making the vaccine policy, and I think this will actually relate closely to a number of the topics we've discussed. And I guess my general theme will be that as we get smarter with our statistics, our machine learning, our modeling, etc., we need to always remember the source of the data, a theme that has come up several times, and the uncertainties in the data, and that when we make recommendations for policy, we need to account for what we don't know as well as for what we have learned from the data and from our models. And I'll make that much more specific. Our group at the Center for Communicable Disease Dynamics has been very active in a number of topics on COVID-19, and this is a list of some of the people, with those in orange being the ones whose work I will mainly highlight. It is now common knowledge to, I guess, everyone in the field that the most important determinant of who dies from COVID-19 is age. And this growth of the infection fatality rate with age in work led by a group in Australia with a colleague of mine, Bill Hannage, as a collaborator, shows about a 4 order of magnitude increase over the lifespan in the risk of dying per infection, and that means that that really about a 25-year age difference is equivalent, or less, is equivalent to a 10-fold increase in the risk of dying. And that huge disparity in death rates is an important driver of vaccine policy. Very crudely speaking, there are 2 approaches to how to prioritize vaccines. The approach of direct protection, where you try to vaccinate those who would be most at risk, in this case, the older adults. And that of indirect protection, where your goal is to break the backbone of transmission, to drive the effective R down. And in many vaccine preventable diseases, that is accomplished by vaccinating children. It seems from the data from COVID-19, of which we've seen several examples already today, that the main groups that do the transmitting are younger adults rather than children and rather than older adults. So at the stage when a lot of different groups around the world, the World Health Organization and the National Academy of Medicine in the US and Science and Medicine in the US, and the national academies, I guess, in many other countries, and I'm sure also at the same time that Korea was making its decisions about whom to prioritize, there were some really important uncertainties in trying to make sense of these strategies. And Natalie Dean and I tried to lay out some of these uncertainties in a short piece that we published in October. And 3 of the key uncertainties really are how well the vaccine works in those most at risk of severe outcomes. And if it works well in those people, it favors direct protection strategy because you can effectively protect them even if they get infected, as long as you, or even if they're exposed, as long as you get them vaccinated first. A second question is how well the vaccine reduces transmission as opposed to simply blocking symptoms. At the time, well, in October, we didn't have any clinical trial results yet. With the early clinical trial results, we had very little data on this question. And as I'll discuss in a few minutes, the data are starting to come out. But the reason why this matters is that if the vaccine works very well against transmission, then that favors an indirect strategy, whereas if it only blocks symptoms, and progression to severe disease, then that would favor the direct strategy. And then the third question is, how fast is the epidemic progressing relative to the rollout of the vaccine? And we've already heard in the earlier talks about the importance of the effective R. And if the answer is that it's moving fast, then that favors direct protection simply because by the time you get vaccine to people, they may already have been infected. And so it makes more sense to try to pull people out of harm's way rather than to slow the spread of the infection, because the timing doesn't work. So the paper that we tried to combine all these questions in is this one, which was published in February. The work was done mainly in December and January. And this was the old-fashioned SEIR model in a relatively simple form, with the important addition of country-specific estimated contact patterns between different age groups. And some of the previous talks, we focused exclusively on age analysis. Those contact matrices exist from detailed database explorations in a number of European countries and other countries. And a very important input into our work was work that had been done at the London School by Prem and colleagues. Those contact patterns to places where surveys had not been done based on their demography, age structure, and other things. When we did that, our comparison considered 5 different strategies: a strategy of vaccinating young people, young adults, all adults, seniors, or all ages. And the first thing that we found was that under most scenarios, if you wanted to minimize cumulative deaths, vaccinating the seniors was the best approach to take. And that's on this bottom graph showing cumulative mortality, which is lowest in the purple. That is not how you minimize deaths. How you minimize cases. The overall case numbers are highest in that policy because those people that you're pulling out of harm's way are not the ones who are doing most of the transmission. And so focusing on the transmitters, as we saw in some previous discussions, is the way to remove people from the transmission chain, but it's not the way to minimize deaths. And this summary slide shows that that the cumulative cases really are minimized by the green policy and the deaths by the purple policy. That's under an assumption of an effective R that's quite high for a controlled epidemic, of course, well below the early values, but certainly below what we aim for under control. You do get a different answer if you assume much better control. So if you can keep the R effective down below 1.2 or so, then once again the number of cases is minimized by the green policy, but also so this is reduction in the number of infections, but also the number of deaths is minimized by the green policy. But notice that it's a little hard to see, but the purple policy, the seniors policy, is not much worse under most conditions. It's a little bit worse, but it is competitive because this is a comparatively easy situation to deal with in terms of the speed of rollout. So with strong mitigation, the indirect policy has more time to work and can minimize deaths, although the differences are small. So these sort of contradictory results made us try to think about whether there was some way to make a decision given the uncertainties. And what we really focused on was this notion that optimization, if you know all the parameters and can predict both human behavior, demographics, and the virus's behavior is one thing. But really what we want to do is a sort of maxi-min or optimizing for the uncertainties and rather than for the certainties. That is, picking a policy that is not bad under all circumstances may be more advantageous than picking a policy that is the best if you predict everything perfectly. And we were reinforced in that view by the sort of delicate nature of the trade-off here, showing different speeds of vaccine rollout and showing that if you have an R above about 1.2, then the purple elderly strategy becomes more favorable, and it's only in the very well-controlled epidemics that the green strategy becomes more favorable. And clearly that is a decision that different countries might make differently depending on their faith in their ability to keep transmission under control for the long term. And certainly variants throw an unexpected, potentially unexpected complication into that. When we looked across different countries of the world using the different contact matrices, we found, again, this sort of different places favored the purple or the adults, younger adult strategy, but never was the purple strategy really a lot worse. And that's not shown on this graph, but when you look at the magnitude of the difference, it's never a lot worse. And then if you assume that transmission is intense, then under all conditions, the purple becomes the favorable strategy. So what I want to do with the rest of the time is to just talk through what we now know. It was mentioned on the first session that changing policies is very hard and requires a lot of justification. But at least as a thought experiment, what can we say about what would be better if we could keep up with our knowledge? So the first uncertainty that's been addressed is how well the vaccine works in the most at risk, namely the elderly and the comorbid. And there was pretty good evidence early, even from the original randomized trial, that the early vaccines worked comparably well in different age groups, at least for the mRNA vaccines, and some maybe less compelling for AstraZeneca. And that was reinforced in a much larger study that I had the privilege to participate in designing in Israel, where looking at the observation of a population, some 600,000 people as they were vaccinated. And what we could see was separation of the curves, very similar to in the clinical trial for symptomatic and severe and hospitalized COVID-19. But most importantly for this purpose, that the effectiveness was 98% in those over 70. It was 95% in those over with one or two coexisting comorbidities. And it was perhaps a little bit lower, but still well within the highly effective range of around 89% in those with 3 or more coexisting conditions. So what about the question of whether it works to block transmission? This is an area where the data really are just beginning to come in. But I want to emphasize that there are really 3 components to this, and a lot of the data that have come in so far are a little difficult to interpret because they tend to mix together these components with other things. But I think in the pure form, there are 3 ways that a vaccine can reduce transmission. It can prevent people from getting infected, which means they can't transmit. It can reduce the duration of infectiousness, or it can reduce viral shedding in those who become infected. So those are the 3 components of process expression for R0 or R of T. And there are different ways that we can study these questions, and I won't go into all the details. We've been working on a preprint here and another one that I hope we'll have ready soon that try to talk about ways to use these different study designs to infer these pieces of information, but many studies are happening already without waiting for our slow production of some methods papers, and they're producing important data. So, for example, the Johnson & Johnson Janssen vaccine in the original clinical trial looked at seroconversion among those in the vaccine versus placebo arm to indicate infection that might not have been observed. And they found, depending on the exact analysis, between 65 and 75% protection against seroconversion after day 28 in post the single dose of that vaccine. So that's the first component and probably the most important component, and quite optimistic information there. You can also infer from the data from the Moderna randomized trial where they swabbed individuals at their second vaccine visit, so 4 weeks after their first dose, and found a 61% reduction in their probability of carrying the virus, a really nice cross-sectional approach. And that 61% is probably an underestimate of the 2-dose efficacy because it was only after 1 dose and there might have been some holdover from before the vaccine took effect. A final type of evidence is that's emerging in preprint form at the moment, unless it's been published in the last week or so and I missed it, is that if you look at people in Israel who were vaccinated and did become infected, their CT values were about 2 or 3 values higher in the period after they had been vaccinated for a while, indicating the onset of vaccine protection. And maybe if you squint, you see an upward trend to an even greater level of protection as time goes on. And finally, with the question of how fast the epidemic is progressing relative to rollout, that is completely heterogeneous across the world. But just as one example, in Israel, there was quite a raging epidemic at the time of the vaccine rollout, the beginning of the vaccine rollout. This is the latest data on the first and second dose coverage in over 60s and in the younger adults. You can see they've just, it's not quite the latest data. They have just surpassed 50% coverage in the population as a whole, in the eligible population as a whole, and reached quite high levels in the elderly. I don't know where that got cut off. And they had quite a raging epidemic going when they started to roll out the vaccine, and you can see that cases continued to grow in the unvaccinated age groups, the 0 to 19, and were pushed down earlier and more in the groups that got most vaccination. And perhaps the most striking change is the hospitalization pattern, where, of course, the older individuals were contributing the majority of hospitalizations, and now, as of a week ago, 2 weeks ago, they are now about half of, or about a third of the total hospitalizations. So in summary, when we think about vaccine policy, it can be used for indirect or direct protection. And what you would do if you were certain about the vaccine characteristics and the evolution of the epidemic could be really either strategy, depending on the exact details. But in making policy that we know is going to be stuck in place for some period of time, we should probably choose something that's robust, that is reasonably favorable under a range of possibilities. In this case, that is prioritizing the high risk. And I think formalizing that in decision science is another step that should be taken. But here you didn't really need much formalization. It was pretty straightforward. But we luckily do have continuous learning that fills our knowledge gaps to allow us to make better decisions. And ideally, we could begin to adapt strategies as our knowledge improves. So thank you, and I look forward to the discussion.
Thank you so much, Mark. And now we are going to turn to your neighbor across the border in Canada. We have the Professor Laura Rosella with University of Toronto, Dalalena School of Public Health. And she's also serving as the scientific director of the Population Health Analytics Lab. And she's also with the Baxter Institute and working on a lot of research in public health and machine learning and other applications. So Laura is going to talk about applications of machine learning approaches to inform COVID-19 management. I shortened her long title in a short way, but Laura is going to be with us. Laura? Okay, we are ready. Sorry, we had some technical problem here, but I think it's been resolved. So Laura, please go ahead.
Great. Okay, just confirming you can hear me okay and see the slides, and I will go right ahead into the presentation. Sorry about the technical challenges. Thank you so much for inviting me. I can't tell you what an honor it is to be here. I've really enjoyed the session so far and learned a lot. And I also just want to acknowledge the special collaboration between Korea and Canada. I've been hearing about it actually for a while from my colleague, Professor Fissman, who has really enjoyed this collaboration and just showed how special it is. And speaking of collaborations, I'm going to speak today on behalf of many contributors to this work, from the Vector Institute, from Layer 6 AI, from the School of Public Health, as well as ICES. And you know, one of the things I'm going to mention at the end is just that one of the silver linings of the pandemic has really been when people come together to solve a problem that everybody's motivated to solve from different disciplines, especially different disciplines within analytic domains, you can really achieve a lot. And that's been something that our team has certainly learned during this pandemic. So the work I'm going to talk about today is really about taking models on populations and using predictive techniques mostly, and trying to make sure that we're matching our decisions to have a more optimal approach. And so there's elements of descriptive, predictive, and prescriptive, if you will, the latter, prescriptive, being the most difficult, and I'll speak a little bit about that. I'm going to share our experience with two specific modeling examples. The first, developing and validating a prediction model to identify those at increased risk for serious COVID-19 outcomes, namely hospitalization. And there's lots of reasons why we chose this model, and I'll talk about how we developed it and how it's being used. The second example I'll speak a little bit about is on mobility data. This is data that's more work in progress, and there's some success in this modeling and some learnings that we're just taking in right now. And so something that I think that many will appreciate if they've worked with mobility data and struggling with it, and also benefiting from it, as we heard in the first session. So I'll jump right into the first model, which, as I mentioned, was a model that is used to identify those at increased risk for severe outcomes to help stratify the population. So what do we mean by that? Well, if we can take everybody in the population in the context that we're in the province of Ontario, we are in a single payer health system. Everybody's covered under one system. If we could know every individual's risk for serious outcomes, we could potentially optimize some of the responses that we're taking. So prioritizing testing and healthcare utilization, the design of more efficient public health strategies, and of course, what we're experiencing right now, vaccine priority groups. And I'd like to add screening also to one of the strategies I think we need to start taking more seriously as a long-term strategy for managing with this pandemic in this year and maybe into next, as we saw with some of the long-term modeling. So to give you just an idea of the data set, every COVID positive lab test is reported into a lab information system. This is data from the first two waves, and of course, as you heard earlier, we are starting a third wave, unfortunately, in our province, and so the models can continually get updated as we have more data. What we have on each and every one of these cases is a healthcare history, and so I'll talk about that in a bit more detail. Before I do want to mention that this model is specifically for adults not in long-term care facilities. So every older adult or adult in a long-term care facility is assumed at high risk. Whatever mitigation strategy, vaccine priority, extra testing, all the measures that we think of in COVID-19 management would be prioritized in this group no matter what, for very good reasons. And so we're actually interested in assessing risk in the population outside of long-term care, and that was the focus. just for context, because there's people from all over the world and you might have a different experience in your setting. On average, our age distribution, is about 50 of our mean cases, and so we have quite a wide distribution, as you can see there, and that may or may not be different than what you're seeing in your particular settings. So I want to talk more specifically about the data that we were trying to make better use of. So we have this routinely collected data, and a lot of the questions that me and my team like asking are we using the data that we have as effectively as we can? And so when I mean the data that we have, because we are in a single payer health system, we actually collect every single healthcare interaction. We have the types of visits, diagnostic codes. We have drug data on subsets of the population. We have laboratory test results. This is more recent data. And we also have a number of demographic databases all linked together and accessible on every individual. And this is routinely collected data. And so the idea here is, can we take this routinely collected data, apply some of the methods I'll talk about in a moment, and actually learn something from these data to help inform our response. When we set up our pipeline, I'll talk about that in the next slide, we always leave a gap between the predictor variables and index date, which is the diagnosis date. And for this specific model, we're looking at COVID hospitalization within 30 days of diagnosis. So this is to give a sense of the pipeline. And I should mention that we've been working on risk prediction models using administrative data for several years for different outcomes. So the idea that we take this routinely collected data and try and generate some insights from it. This is actually a description of a pipeline of a risk prediction model that we developed for diabetes complications. We started this work several years ago. And I put it up here just so you get a sense of what the routine collected health data looks like. It's very transactional and quite messy, because why a certain individual sees a physician or has a particular procedure is very variable in the population. Obviously, it's related to their risk. It can vary by demographic, it can vary by their access. And so we developed this sort of pipeline to try and make sense of all that data. In this particular case, we're taking a sliding window approach because we're looking at diabetes over a long period of time. For COVID, we're really just looking back at the 2 years prior to the index date. And we have found, using this type of data, and given the granularity of the data, that gradient boosted models, and specifically XGBoost models, work really well. We've tried lots of different models, and I won't go into lots of technical details, but they work really well for good reasons on this particular data. It's as I mentioned, transactional data. It's not particularly deep data. We don't have deep clinical information. We have lots of information about how individuals use healthcare and the type of tests that they're receiving. So to give you a sense of the model, we did a fairly typical training and validation, hyperparameter tuning on 47,000 patients. We did it out of sample test to test the validity of the model. I'll show you the performance. We summarized it or got it down to about 18 variables in routine data. And again, we try to make this model usable, adaptable. The idea and concept adaptable in other jurisdictions. Many jurisdictions collect this type of data. Sometimes it's in a health insurance model. Sometimes it's on the full population from government-led healthcare like we have in Ontario. But the idea, the approach, the pipeline could be adapted in lots of other settings. Give you an idea of the types of variables that go into a prediction like this. Some lab values, you'll see obviously some demographic values like age and sex and geography, which is very important in our context. Professor Frisman alluded to this earlier. Types of tests and intensity of tests, so the number of times an individual sees a particular healthcare provider for particular reasons. Some Shapley values here just to give an idea of the variable importance. Again, this is a prediction model. These variables aren't meant to be interpreted causally in any way, but you can see what's contributing to the predictions of severe outcomes. perhaps unsurprising to many, but I think important to note again, things like where an individual lives, whether or not they're living in an area of low socioeconomic status, or we name here marginalization, which is one of the ways we measure this using census data, their age, and then some of the other healthcare utilization variables. So just to jump to performance, the model actually performs quite well. We have an AUC of about 0.85. We looked at calibration to make sure we weren't systematically over or under predicting in particular groups, and the calibration was also worked very well, very comparable to many models that actually have a lot more detailed clinical data. And so the trade-off here being, can we use routine collected data that's available for everyone on the population, and that we can run at all times and still achieve good performance? And we definitely saw that we were able to do that. So we thought we'd compare against some empirical rules, and this is useful when thinking about how a model like this might be applied. So for example, if we're trying to think about vaccine priority groups, if you just had looked at ranking the population by age, or age and number of comorbidities, which is again a very popular strategy for identifying who should be vaccinated first, we're able to show that we are able to have greater recall with this type of model. And, there's good reasons for that. We know, I mean, we all can and see in our population that, yes, on average, it's older adults that are at risk versus younger, or those with comorbidities versus those that out, but there's lots of cross sections. So a model like this allows you to compare and take into account lots of information. For example, you might have a younger person who lives in a socioeconomically deprived area that actually has lots of comorbidities. And how do you weight that against an older adult who's actually, well off, very few health conditions, very few medication? How do you weigh these two things together? So again, this becomes one input in the way that you might want to think about risk distributions in a full population, capturing data that you actually have on everyone in your population. And this is, again, another comparison of recall, but using some of those empirical rules and even some simpler statistical models. Certainly, you could use a simpler statistical model like logistic regression. I think the benefit here, and I'll speak to this at the end, really is when you do have that messy, very highly transactional data, you can sort of squeeze more out of it, the more analytically flexible approaches that you're using. And many of these machine learning approaches, in particular XGBoost here, which isn't definitely not the most complicated machine learning model, certainly is more flexible. When you have this complex data, you can get more out of it. So I should mention, of course, we don't have detailed clinical data, which is potentially a limitation. But as I mentioned, we're seeing performance similar to models that do have clinical data. So I think that for the purposes of population planning, there's lots of potential. Of course, you could focus on other outcomes, ICU specific or mortality. I would argue, though, hospitalization is probably one of the most important. It's both clinically meaningful, it's important to patients, it's also important for the health system, which has been a big focus of our public health strategies in terms of protecting the public health system, which has been very hard hit in our jurisdiction and continues to be. And then implementing and actioning the model is always the hardest part. We can generate these really great models that are actually really effective. How we convince and work with decision makers to use these models in practice is a challenge. It's a bit of the science and art we heard about earlier. There takes a lot of trust building, actually. Many modelers know this already, that you actually have to work with the decision makers for a long time. They're not always going to understand the technical aspects of your model, and that's not the point, but they do have to trust the process and the outcomes and see that the models actually add value. And that's based on relationships and a lot of work, and ideally that those relationships are established before a crisis hits. Okay, in the last few minutes, I think I've made these points. I'm going to move to our experiences using mobility data, and the motivation for this work was really at unpacking the local heterogeneity we're seeing in our region. And this is work with Vector, and we're looking at whether mobility data can actually give us insight into some of the local area heterogeneity that we're seeing. And I'll show you some maps to show just how heterogeneous it is. And we saw in Professor Murray's presentation that mobility data being very useful. We are not using direct mobility data, so that's one explanation for some of the findings that you're seeing, but we have lots of different millions of data points really from different points in time. This is the map I want to show you. This is, again, data from ICES, just looking at our particular province, and you have these areas called forward sortation areas, which are the first 3 digits of what we would call our postal code, small area geographies, and you can see just how much variability there is. We have regions that have been hit very hard consistently. This is not a region that gets hit hard and then it's done for them. It's been actually the entire pandemic. And I work within a hospital in Peel Region. Professor Fishson pointed that out earlier, to try and help with operational planning. And we sort of see these persistent trends all the way through. And could the mobility data provide some insight into some of these geographies? And it's not just, mobility data as one data point. There's lots of dimensions. So how many people are gathering close together if we look at device concentration, how far you're going from the home, the combination of mobility based on where you are, and out-region movement, so movement between different particular areas. And what we're seeing here with this data, this is just some of the descriptive aspects. Certainly this data has been very useful at seeing how the impact of the lockdowns. And so we see that in different regions and different groups, the impact of particular public health measures on mobility. And so from that perspective, it was very useful. We tried several models, machine learning based models. The punchline is actually we had a lot of noise in this data. And when we got more complex with the data, the modeling, we actually saw a lot of overfitting. And so the more statistical based approaches actually worked much better in these particular situations. And so that's just a learning that was quite interesting from working with this data. The other last point, result I'll show on this is that the mobility data really added value for local area predictions the further out you went. So if you're just trying to predict 10 and 14 days out, it wasn't adding a lot of value. But when you start to get 50 days out, those patterns of mobility do tell us something about the expected rise in cases that we will see locally. So just the take-home points from this particular example is that the mobility data on its own certainly can be used, but will improve with linkages. And so we saw in the second presentation from Professor Park about all those other elements from the census level data that really need to be integrated with the mobility data. Some of those regions actually, there's a lot about essential work, multi-familial dwelling households that are critical to integrate with the mobility data. And we're still doing some work on the dimensions of mobility, where people are going, points of interest, which is also quite critical. So overall, I just hope with these two examples, we've been able to share the considerable value in routinely collected data, mobility being one that we've really embraced in the pandemic, but also routinely collected health administrative data, which tell us a lot about individuals, and they tell us a lot about individuals' risk. And this data has typically been used to think about individual risk, but there's considerable value with thinking about it for populations. The integration of multiple data has been critical, especially demographic and socioeconomic data. Those elements define risk in ways that simply will not get the same level of prediction and accuracy without considering them. And so that's been critical in our work. And then lastly, the right method for the right problem. Certainly, we go into a lot of these modeling exercises thinking that we know which method's going to work well. And we've come to realize that oftentimes There are simpler methods that work much better, and that's driven by the data mostly, and also the particular problem, but also sometimes the complex methods have allowed us to unpack insights that we just wouldn't have seen before. So sometimes it's unpredictable, but just making sure that that fit is right. And then the last thing I'll say, I said this at the beginning, was the key to success for us really in this collaboration has been having access to data on full populations. There's a lot of selection bias when you're picking and choosing particular data sets. And so having population data where you can see the full heterogeneity has been key. The methods point, which I made earlier, and the connection to the application space. So really talking to the users who are going to use this data, public health authorities, I mentioned working with hospital operations teams. What do they need out of this data? What decision will they make with this data? That really drives the approach in the beginning, and how you could frame and work on a problem many different ways. So I will pause there. I really look forward to the discussion, and I just want to thank my funders and all the collaborators from all the institutions that we work with. Thank you.
Thank you, Laura. I think we heard a number of really good models that she's been constructing and actually using them for the actual practical work. So I'm a fan of this linked data that she mentioned, and also a lot of this mobility data that she actually discussed about, and we'll get to it later on. So far we had presentation by 4 speakers. Now we have 2 distinguished discussants to address their comments and questions on these presentations. First, we have President and CEO Alan Bernstein of the CIFA, based in Canada. It stands for Canadian Institute for Advanced Research. And he's been leading the CIFA since 2012. And he also served as the founding president of the Canadian Institute of Health Research. Prior to that, he served as executive director of the Global HIV Vaccine Enterprise based in New York. And I think one thing I'd like to add here is that Alan has made landmark contributions to the study of stem cells, blood cell formation, and cancer. So we are very honored and very pleased to have Alan with us, discussing his, I think, the points based on this presentation and other insights that he can share with us. Alan?
Thank you. Can you hear me?
Yes.
Great.
Very well.
Well, I am really very deeply honored to be invited to be a discussant at this meeting. It's been a feast of science all evening, and it's getting on to be midnight here, but I'm still wide awake because what great science we've been hearing all evening, and it's important science. It's no secret we're in the middle of a global pandemic, and so this science is obviously important and relevant to the health of the whole planet. And so this has been, I think, kind of a historic occasion. And I want to thank Young and everybody else who's been involved in organizing this meeting. To me, as was noted at the beginning, there are 4 speakers from 4 countries represented here. And I think the scientific community has, in addition to the science, has a great deal to add to show our policymakers in the political world the importance of global collaboration at a time like this. Obviously, none of us, or no country is going to get out of this pandemic without global collaboration. And I think there's been a number of references between the collaborations between Canada and South Korea, between David Fissman's group and Laura and others with South Korea. But it doesn't stop there. One of the things we should keep in mind is the sequence of the virus that enabled Moderna to quickly make the RNA and start their vaccine work in mice and then in humans. That sequence was released by the Chinese in the first week of January and put on the web. That was, to me, really mark the tone of global collaboration right from day one, which is The Chinese shared their sequence with the planet, enabled Moderna to make a vaccine in less than a year. A remarkable example of global collaboration and partnership that made all this possible. Well, you know, the session that I've been asked to comment on is a really interesting one, because on the one hand, it is about how to analyze very complex data sets, going from statistical methods, other methods, machine learning methods, and hopefully affecting policy. And Laura, you talked about trust between the scientific community and policymakers. I think you're the only one who made that comment, so it's struck with me, because my own experience, which is all too considerable in terms of dealing with policymakers, is it does come down to trust. And you made a second comment, which I would totally agree with as well, which is that trust has to be established before there's a crisis. It's very hard to start new institutions, to start new relationships of trust after a crisis has been started. Because once you're in a crisis, of course, decisions have to be made with imperfect evidence quickly. Because if you let the virus get ahead of you, you lose. You need to really establish a quick method, a quick psychology of decision making, and you rely on people at this meeting to provide you with data that you can trust. So one of the things I'd be very interested in hearing about from all four speakers who have had experience with this is how do you present in a filtered way to policymakers who will not understand and don't have the time to understand how you got to your conclusions? How do you talk to them to make them appreciate that they can trust what you're telling them, while you're not talking down to them, but certainly presenting the data in a way that's clear, irrefutable, and it's distilling complex data in which you've had to make some assumptions, which may or may not be valid. And so there's always areas of uncertainty, and a point that Mark made in his comments about what don't we know as we're moving forward with this data, and how do we make decisions based on that. And when I hear these sorts of examples, I'm always reminded, given my own background, going back to, but this is way before my time, going back to cigarette smoking. So there was really very, very good epidemiological data coming out of initially the UK, but then other countries, that of course the association between smoking and lung disease and lung cancer and other ailments. And yet it took decades to convince policymakers to change their mind. And there's lots of case histories have been written about what the issues were. But I think it is interesting that during this pandemic, how closely, not 100% of the time, but how closely policymakers, certainly in my country, and I think in South Korea from what we've heard, how closely our elected politicians followed the advice of the scientific community. Even when it involved making tough decisions. Locking down the economy, locking down people is not a trivial decision for a politician, for anybody to make, but especially an elected politician who gets reelected on the basis of his or her popularity. And so how do you make those tough decisions at a time of crisis like that? So I think I'm very struck by the title of the sessions and all the titles of all the talks: science-based policymaking, lessons defining readiness for a new normal. And I think it's a great title, because I think it does capture one of the challenges we're facing. Because when we come out of this pandemic, so I know we're talking about this becoming endemic from the last session, but I'm an optimist, so I'm going to assume we're going to get rid of this virus for a moment. I think our next big challenge is obviously going to be climate change. And there'll be similar kind of conversations to this one, the context not being the virus, but the context, of course, will be what are the factors and the variables that are contributing to climate change. And some people have argued that the stakes are higher. I'm not going to get into that game, but there certainly are high stakes today, and there'll be high stakes tomorrow with climate change. So one other lesson, and I was reading The Economist from last week, and there's a whole section of their Technology Quarterly, which I can highly recommend, talking about the pandemic and the science that's gone on in vaccine development, the science in predicting. And in the predicting session, which I read closely, anticipating this meeting, they talked about the very first predictor. It was a guy called Robert Fitzroy in 1861. And he published in the Times of London the first prediction of weather. It was the first weather forecast. And he was wrong. He was consistently wrong about the weather, which is hard to be wrong about the weather in England because it always rains. So I don't know how you can be wrong. But anyways, he nevertheless, I will bet 50% of people who read the newspaper and the hard copy look at the weather forecast first. Or they might look at the COVID incidence cases, but under normal times, they look at the weather forecast, and we expect it to be accurate, at least for the first few days. So the idea of prediction and the public's interest in prediction really started with weather forecasting about 180 years ago, 170 years ago around weather. And of course, it matters because a lot of lives can be lost if you make the wrong prediction around weather. Indeed, in those days, a lot of lives were lost if you made, at sea, if you made the wrong predictions about weather. So in terms of, we were talking, of course, about this pandemic, but I think it'd be interesting to think about the kinds of analysis and the kinds of technologies that we heard from our four really great speakers. Can you use the same technologies to predict future pandemics? What are the variables that will predict future pandemics? So climate change may be one, the increased density of humans in urbanization, the density of humans and animals at the markets, our farming practices, etc. But what are the future pandemics going to look like, and when are they going to happen? Can we predict the course of this current pandemic? I mean, we've had people talk about waves and being willing to say that there's a next wave. And David Fissman and Laura are well known in the Toronto area for predicting what the next wave is going to look like. I'd like to know the prediction of the whole pandemic. How do we meld in all the complex variables of the vaccine efficacy, the variants of concern, where all this is going? Can we accommodate all this, perhaps using machine learning to look at these complex things? Because these are simple predictions are simple to do. Complex predictions are hard, but that's what we're dealing with. So can we be a bit more ambitious in terms of our predictions? So I'd be interested in hearing from the four speakers about that. And then obviously, these pandemics, by definition, are global. What about predicting around the role or the fate of the pandemic in different parts of the world, and how it's going to affect other parts of the world? We are an interconnected world, even with the cutoffs of travel. That's not going to last forever. It can't last forever. How are we going to deal with all of that going forward? So I'm going to stop there. I'll be very interested in hearing people's responses. My comments have been deliberately broad and vague because I wanted to have an open discussion about how we engage with policymakers given the complexities and the uncertainties in the time of crisis. How do we predict the future beyond what we've been doing so far, using all the tools we have at our disposal? And I would suggest we haven't been using all of the tools yet. I'll be interested in people's remarks. Thank you.
Thank you, Alan. I think he raised a lot of global questions that we got to deal with in response to this global crisis that we are currently facing. So I think the presenters, I think will think over those questions and comments while we are going to listen to the second discussant. Director, Dr. Junwook Kwon, He's the director of the Korea National Institute of Health. He's also the associate director of the National Committee of the Epidemic Control and Prevention. So he's actually, doing the day-to-day work on this COVID-19 pandemic in Korea. So actually, many of POPC people have seen him on TV and then reporting on daily incidents and a lot of, I think, the actual mechanisms that we have in place. So we are very actually pleased to have him and listen to his comments and then perhaps some questions that he's going to raise to presenters. So Dr. Kwon, please be with us.
First of all, thank you for inviting me in these great presentations, and it's my honor to be one of you. All of you are very famous persons, and thank you for all of your presentations. Actually, I'm the second person in the front line of combating COVID-19 in Korea. So you think that I am working in the real world. And first of all, I want to apologize my two areas. First of all, I could not concentrate on this seminar because every morning in Korean time, almost 4 hours ago, we have a daily meeting. So I could not concentrate on all of your presentations, but I read all your papers. Second area is my language. English is not my mother tongue. So I want to say on my best to all of you in English. Today, I want to share briefly the situation and troubles in Korea. In that contents, you can please give me the answers or opinions according to the Korean situation. In Korea, since last February, we have third waves. First wave starts with religious groups in Daegu. They have a very high peak of coronavirus. Second wave starts in Seoul area with the entertainment facilities. And right now we are still on the third wave, and the third wave is very complex and various areas and various groups. Every morning, Prime Minister hold nationwide COVID-19 response meeting. Weekly, we reviewed the basic reproduction number based upon model, and nationally, regionally, we reviewed the future predictions. Also, we used the use of credit card and the use of mass transit data. We estimate the mobility. Whenever Prime Minister holds the meeting, many high-ranking officers complained the accuracy of prediction because sometimes the modeler predicts high peak of COVID-19, however, subside. On the contrary, sometimes model predicts low incidence in certain weeks later. However, sometimes we faced reverse high peak of COVID-19. So that's very our difficult challenges for us. I think that the COVID-19 model have its own difficulties. First of all, COVID-19 is a droplet transmission mode. Even in certain situations, COVID-19 airborne transmission. Also in real world, very complexity because all of you already know that COVID-19 in real world, there is no homogeneous mixing pattern. Always there are certain core groups, various contact patterns. Even in COVID-19, there are so many asymptomatic infections. Also, how to make a model to project rigidness of social distancing. That's our another challenge. The other area is how to consider the natural acquired immunity. Also, how long longevity of antibody. Also, Korea started late February, started the national vaccine program, how to project vaccination program into model. Finally, we have faced new emerging variant. Variant is totally different story. So how to model, project, or incorporate these real-world variant into model itself. So there's so many challenges for us. I wonder your opinions and your answers. After reading the Dr. Park's presentation materials, Dr. Park points out the importance of age. In Korea, including me, high-ranking officers want to answers in real world, such as Vietnam, Taiwan, New Zealand, Australia, all of the Asia and Oceania countries, they have so much high level of population density. Even that, Taiwan showed us very few COVID-19 cases, even Vietnam. So what's the answer could be? So that's always ask me, high-ranking officer ask me why the similar situation, however, they do not show high level of COVID-19. So that's another challenge for us. Maybe just not only age, but also other factors could be more influence the COVID-19 epidemics. Finally, I want to reiterate how to increase the predictability of our model and how adopt that model to real world. That's a very challengeable hallmark for me. So in that area, I expect your answers and opinions, so many good advices. Thank you very much.
Thank you, Junok. It is now time for some conversation between presenters and then discussants, and perhaps some of the questions that we are going to hear from each other. So I think in consideration of the different places that I think we are talking to each other, so let's give about 2 minutes to each speaker to respond to questions that Alan and then Junok raised. One set of questions are pretty global. The other set of questions are pretty specific geographically regarding the Korean case. So hopefully you can address some of those questions, and I'm not going to repeat those questions by myself, and then you know what they are. So let me first turn to Laura, so you can address some of those questions and comments as we heard. Laura?
Great. Yes, thank you for the opportunity. I'm going to start off with the modeling and policymaker questions that actually were brought up by both discussants, and what I think is needed to make sure that that relationship works well. And really, I think it's transparency, reproducibility as being key. And things that those are two things that actually have changed quite a bit during the pandemic in our context. The idea to make data available to a wider group of individuals to make sure that the results are reproducible by others. These are critical things that I think that we can do a lot better on, and certainly we've been doing a lot better on this in this way. But I'd like to also just mention something that we have in our context that might be unique, and this is a modeling group that's chaired by Professor Beata Sander and Kumar Murthy, who take several modelers from lots of different universities and research settings, and the questions come from the policymakers to this modeling table, and consensus models or several models respond back. And this is an excellent mechanism because it's not just the opinion of one particular model or one particular group. It's actually perspectives from multiple individuals, all who have access to open data. And these are the types of things that I really think improve that relationship in terms of translating the models. The second thing I wanted to mention was in response to Alan's questions on how do we predict in a situation where everything's changing at all times. And I'll say even more than that, it's not just changing because we have an uncertainty, but we're actually messing with it. We're closing things down, we're opening things up, we're implementing measures. I mean, typically to do a prediction task, you have data over a period of time that helps you understand the phenomenon, you train that data, and then you apply it. And we have the exact opposite situation. We have constant change and we're bringing on our own change. So what can we do in that situation? This is where I think we need to shift our thinking from a typical medical model where we have a model that exists and those parameters exist for a period of time. These models are living and actually need to be updated as quickly as even daily in these circumstances. And so that shift to a living model mindset is something that actually takes a lot of people, a lot of getting used to, including modelers, because that's not the way that we're used to thinking. But certainly operations researchers, computer engineers do think this way. And so the idea that predictions need to be updated frequently is something that's quite critical. And so I'll stop there because I think I've used my 2 minutes, and if there's time, I have things to say on the other points as well.
Okay, thank you, Laura. I think we'll get back to you later on when we have a little more time. So now let's get back to Mark to answer some of those questions and comments from the discussants.
Thanks. So I want to start with also the question about trust from decision makers. I agree with Laura. I would add a few concessions. One is, indeed, we do need to establish these relationships in peacetime. That's utterly critical. And I think related to that is really the need to build capacity and partnerships, to build capacity in government to receive and process and critically evaluating and complex data analyses. And importantly, I think partnerships, Gabriel Lund is no longer on, but is really an inspiration to me in terms of the role that partnerships between academic and government scientists can play, even in people being the same people with dual appointments. I hope we will move in that direction in the US. The UK does it very well. Some other countries do it well. Hong Kong is one of them. In the short run, we have, what do we do now? I think it's important to work through when we're speaking to policymakers and explain, you might wonder if this is robust in this way. And I wondered that too, and this is how I pressure tested it. And I think it's important to try to understand, and this is really a two-way street, the decision makers have help. Try to understand the decisions they're making, the considerations on each side, because often, even when there are scientific uncertainties, the right decision is more clear than the right science, because they're not being asked to put a p-value on a hypothesis, asked to do something and save lives rather than fewer. That is sometimes harder and sometimes easier, but important to figure that out. That's sort of what my was about in a way. I want to push back about the critique of and prediction and the call to try to predict the whole pandemic. I think that would be like being an ancient Greek prophet. And the problem with the ancient Greek myths is that people make predictions. They are going to come true because they're prophets. Then everyone spends their time in futile ways trying to evade that prediction, and it comes true anyway. If we're doing our job, we make predictions that then become the goads for evasive action effective. And I think there's a fundamental limit, and Laura sort of said this, but I'm just giving it a little bit of ancient tinge. So I really don't be making that are right. I want to be making if-then predictions. The very fundamental difference between whether on hand and epidemics on the other is weather is an autonomous system. Our umbrellas do not affect that, but face masks affect the transmission. And I think really a difference. So I think predictions have been bad indeed over any more than a time scale in this epidemic. And there are a lot of bad reasons for that, like unpredictable policies. But I think one good reason for that is that a significant prediction should generate evasive action. So I have a lot more to say too, but I'll shut up.
Okay, thank you, Mark. Now let's turn to the continent where I'm speaking at the moment. So we have Taesung with SNU. He actually got a very specific question from Junuk. So would you address one of his questions, and plus any other thoughts that you can share based on the comments that you heard from the discussants?
Okay. First of all, I'd like to talk about some policymakers and scientist relationship. As you told us, I think trust is the most important part. And I'm very lucky to live in Korea at this pandemic area because I've seen that there are a lot of good collaboration between scientists and policymakers.
Please speak up. The voice volume is very low and.
Sorry. Okay. All right. I think I'm very lucky in staying in Korea in this pandemic area. I've seen that a lot of good collaboration between the scientists and policymakers. For example, the Korean CDC have a regular input from the modeling groups. So they try to their best to incorporate the modeling results. And also like the Young collect all the modeling information from different scientists, and then he provide all the information to like the prime minister groups to help to make a good decision about the modeling steps. Okay, so I think we do have very successful, and I'm proud of the Korean government about the modeling. Okay, I think you issued a very critical question here. I spent a couple of days to summarize what our group and our students have worked so far. So I present three freeze data. First freeze is about the data collected from the end of August. Second freeze is about the end of the last year, and we are working on the recent data set. It turns out that the data are going to be much more complex, and the patterns what we observed from the first freeze data, earlier set of data, we could not find the same pattern from the second freeze of the data. That means the data is very complex, and it requires much more complex and sophisticated modeling analysis. So at first I thought one of the big model which can show the overall global pattern would be okay, but now I changed my mind. Very specific, like country specific and even region specific and some group population specific modeling would be helpful to provide them very accurate predictions. Like for example, in Korea we have the domestic model. That model would be different from the Seoul area model and the other rural areas. And if you go to some urban areas, the modeling should be different. So those kind of sophisticated modeling should be required. Okay. And about the Junuk's question about the age. So what I presented here is global effect. I just combined like more than 100 countries, and then I reported average result. That result would be different if we focus about specific individuals, specific countries, right? So in other words, it would be desirable to fit the model Korea only, and Vietnam only, and Japan only, specific country-based models, and then based on those models, we can see the effect of the like age-specific effect, right? That kind of country-wise modeling would be required. But what I just presented right now is about global effect, just global patterns. So that would be a little bit different from the country-specific result. Okay, that would be my answer.
Okay, thank you, Taesung. So let me briefly say a few words in response to some of those comments and questions. perhaps I can tell you about sort of personal story of the how academics, modelers, and then decision makers and government have been working together since February of last year. It's a long story. To make it short, I think as Tae-sung noted, I've been taking the role of sort of catalyst, or sort of the bridge between different components, perhaps the key blocks dealing with this COVID-19 pandemic in Korea. So I'm very actually pleased. Junuk is with us from Korea CDC. So he and I actually has been talking a lot, and then using the models that I pulled together initially. I think based on these models that David Fishman and Statistics Research Institute of Statistics Korea have been working together. So that was for the first 6 months, sort of phase one. And then, I was thinking about, we need to have, I think a lot of different models and multiple models working together. And so I've been asking modelers, mathematicians, data scientists, statisticians working together, and then present their models together. And then I put together those models as a kind of set, and then provide sort of, what is the sort of, fair, and then I think the way of representing those models, and then relay those to decision makers in the national committee of, working on controlling and preventing this COVID-19. So we continue that kind of communication, almost every week. And then I told you about those 25 models that we have put together in the past 12 months. So every time we put those models, and then I made sure that key persons in the decision-making body actually get it, listen to it, and then make decisions based on data and science. This was the sort of foundation of the so-called science-based policymaking or evidence-based policy crafting. So that is the sort of, I think, a principle that we have guided. Of course, there are sort of ups and downs. Sometimes some of these models were not necessarily accurate. There are some amount of uncertainties. So there was a time that we are not sure whether, this particular wave of the epidemic, I think the curve is just going to be flattened. But so far, I think we've been having that kind of communication, and that was actually creating good amount of trust between scientists, modelers, academics, and then policy decision makers. And that was the case. When it comes to sort of this question of the impact of the variants and on the pandemic itself and then modeling, this is not an easy question. I think this is a sort of double-barrel question I consider from both the Alan and then Junuk. If I extend this question just like Alan sort of suggested, can we predict next pandemic beyond this COVID-19? Probably we could do that if we collaborate together across continents. So far, we've been doing all these battles within individual continent. There are times that we collaborated between Canada and Korea, between Korea and the United States, between among the certain countries. But in order for us to be better prepared for the another round of the pandemics of very different kinds, it is very important that we talk to each other and share the data, and then build sort of this common ground and common sort of consortium. I've been thinking about this sort of pandemic, research consortium we can together internationally, so we can be better prepared. We learned a number of good lessons this time, based on this COVID-19 pandemic. But this is just one case. Just like Ellen noted, we got to be better prepared. But we learned the good lessons. We can now, for example, let me wrap up my comments here. I think we can learn even from this data, and then I think things happening in Latin America at the moment. Because of this particular variant impacting, sort of how this epidemic curve is actually changing very radically. We got to learn from their case, and then we got to be better prepared. And we can create sort of very positive cycle of the collaboration if we talk to each other, just like we are doing today. Just over the virtual space, we can do this kind of collaboration. So I'll stop here. So let me go back, perhaps to discussions here. Alan, you heard our response and then comments to your questions. Do you have any thoughts and insights that you'd like to share with us?
Well, just to pick up on
to Alan.
Yeah, just to pick up on your last comment, the world financial system has developed sort of a way after 2008 and the financial crisis for balancing out things. And so perhaps just to pick up your point, maybe we need, I'm not sure we can predict the next pandemic, but maybe we need a way of having a much more structured multilateral international organization that will work together, sharing early warning systems. And there are a lot of very interesting immunological models of early warning systems to look for emergence of new viruses, new pandemics, and not just immunological. Blue Dot had an AI-based way of detecting something abnormal going on. So I think there are some methodologies one could use to certainly detect something abnormal coming out of a country, and based on that, decide what to do. So yeah, I think it's an interesting idea. I said, could we predict the next pandemic, to be a little provocative, but I think, assuming one does break out soon, I think it'd be very interesting to see whether one can't develop a global approach to dealing with it, other than the kind of makeshift mechanisms we have now. The other, quote I had from reading that Economist magazine, which I thought was interesting. It's from, if I can find it in my notes. It's Jim Kim, who's the president of the World Bank, made the comment that, and it's psychologically understandable, we go through a period of, and all of us are like this, of panic, neglect, panic, neglect. And let's hope we don't, let's hope we learn from this particular lesson and don't go into a neglect mode as soon as we think the pandemic is over and we don't need to worry about the next one. And so that we don't, and then panic when it comes along, that we actually prepare for it. And I think there's a lot of great science that still needs to get done to prepare for it in, like I've been saying, in very sensitive ways that we haven't even begun to tap. There's probably about 1,000 different families of viruses. It would be very easy, I think, to multiplex detection methodologies to detect any one of those 1,000 families emerging in a population very quickly and very sensitively, either using DNA methodologies or immunological methodologies, and we could institute that on a routine basis. So I think we need to start thinking more in that global way so that something like COVID-19 doesn't happen again. And if you think about the cost to our economies in the world, never mind the human cost of trillions of dollars, to even invest 10 to 20 billion to set up such a global scanning mechanism is cheap. It will be very inexpensive.
Yeah, I see the smiles on the face of Laura. Perhaps Laura has just indicated she has a few words to say. Laura, would you like to say a few more words?
Sure. So, I mean, I definitely agree with the global collaboration piece. And what I would say is, instead of thinking of preparedness as being able to predict and know what's going to happen next, I would love to see us talk about preparedness in terms of building infrastructure for rapid learning. And when I mean rapid learning is that we have the data infrastructure so that all the questions that we want to ask, the data access, the really complex data architecture that we heard about is set up, and so that we could rapidly respond, learn, and generate those questions and answers to those questions in a quick way. So it's less about being prepared in that, oh, we know it's coming. It's more being prepared in that we're set up analytically to have rapid learning in an uncertain situation. And I think that thinking is also more helpful, because sometimes when we think about preparedness too carefully, we actually start framing assumptions that make us hard to move off of. A lot of the decisions we made in the beginning is because we made assumptions based on either preparedness plans or what we thought we knew about the virus, and then changing once those are off it's hard for the public to understand that, it's hard for scientists, hard for policymakers. And so if we go into it knowing that we're not going to know, but we're well equipped to answer questions quickly and have infrastructure to do that, is how we need to be thinking about global preparedness. And then I guess one more thing I want to add on the climate piece, of course, climate density, all these things being very important. I think we also need to start monitoring and understanding geopolitical relationships, which again is something that we aren't maybe typically used to modeling, but the types of geopolitical relationships in the world actually have a huge influence on some of these factors, and have an influence on things like agriculture and all the other big systems in our world that actually contribute to a lot of the viruses and the emergence of particular viruses. So something I just wanted to add there.
Okay, thank you. Mark, would you like to say a few more words? And then also I suggest if you can respond to some of those burning questions that Junuk raised using the Korean case, and that'll be nice.
Yes, I certainly meant my comments earlier to be responsive to his questions about the prediction in Korea, but it is a matter of perspective, and to what Laura just said, there has been learning. I think the scientific community learned that that vaccines for pandemics needed to be developed rapidly and invested in CEPI and in multiple platforms, not just CEPI, but platforms for development. And as it hadn't invested in a virus vaccine, not coincidentally because of the South Korean experience with MERS. And sitting in the United States, where we've had one of the worst responses in the world, it seems to me that while Korea may say, why are we not Taiwan, the United States, a lot of people are scratching our heads and saying, okay, we can't be Taiwan, why aren't we Korea? And I think one of the answers is that Korea had the experience of MERS and learned not only how to learn, as crucial point Laura raised, but also how to respond. So I'm a big pessimist, but I think in this respect, we learn one lesson at a time, one place at a time. One of the aspirations of science is to be a bit immersive. David Fissman and I were in a conversation in the chat about how everybody seems to need to learn things in their own jurisdiction. They don't believe it if it happened next door or across the world. So I think as scientists, we can aspire to believing or to convincing people that the lessons of elsewhere are the lessons for us. But I guess it's not a response to Dr. Kwan's question, but I think from my being Korea is enviable position, even if it's a difficult one at this moment.
Junuk, do you have any further questions or comments in response to this question, the comments and answers that you heard from the speakers and discussant?
Just shortly speaking, I'm deeply appreciated your time and your comments. And at this time, not public officer, as a scientist, I firmly believe that mathematical or any type of model make us right to do things in the area of public health. So I want to return to basic principles of democracy. So participation of many persons to make a model, and also transparency and communications and openness. As Dr. Park and Dr. John pointed out, that inside of a government, always there is a double-sidedness. Many persons want to write prediction of model. The other many persons say that the protection of privacy. So they want to oppose to openness to the data, to outside. So again, I want to make my comment as a scientist. I remind myself as a scientist, right model is very important for us to make intuition to the future. Finally, I think that we have another example of influenza. Influenza is a similar transmission mode, and we have a very enough data set, so we can apply our model to the influenza epidemics and make some evidence to understand the high-ranking officers which model is suitable for the predict the future. That kind of things. And the other area is I want to make the many modeler invite inside of government to say and speak with high-ranking officers directly. So anyway, in conclusion, I will do my best as a public officer in the modeling, more contribute to our combating COVID-19 in Korea. Again, thank you for so much your invariable opinions and advices.
Thank you. Speaking of models, now I think we have one of the modelers here from a statistical perspective. So let me get back to Tae-sung, if you can address some of the remaining questions or comments that you just hold your thoughts. So do you have any additional words you'd like to share?
Yeah, this would be my final comment. As a statistician, I first analyzed the COVID-19 data. I first applied simple SCIL model and then applied Poisson and segmented Poisson and negative binomial. As you can see, I was evolving in fitting the model. So as a modeler or modeling results, we are evolving, right? In Korea, we have some experience about MERS. That's why we have better result, right? So today is better than yesterday, but I believe tomorrow will be better than today. We are doing our best to have the good, accurate modeling results. Thank you.
Okay, thank you. I wish we had more time, but I think we are actually behind the schedule. I gave us 25 more minutes than scheduled because we had some technical problem, and I think we had a longer also section in the first section. So let me just conclude our section here. Again, I think the Prime Minister of Korea indicated in his congratulatory remarks this morning that I think the collective insights that we are gathering today in this symposium be a catalyst to accelerate the global recovery as well as the K recovery. I think he said in a right way. I think we are putting together collective insights and collective wisdom here today. And I'd like us to continue this kind of conversation. So I think we can learn from each other and internalize the lessons. And just like Alan said, this is just the beginning of this I think the transcontinental collaboration. So we can be better prepared for the next pandemic or any other kind of concerns I think affecting humanity. And that's why I think we are working together, and we have different sort of training. But I think in many ways we learn from each other today in two sections. We are working together in a transdisciplinary way. And then that's why we are learning from each other. So again, I like to say my, I think the heartfelt gratitude to SIFA and University of Toronto, Harvard University, and also the other universities, I think who joined this morning, the MIT, University of Hong Kong, and also Seoul National University, and University of Washington, and Konkuk University, and Statistics Research Institute, and also lastly, National Research Council. And also I'd like to say again, to appreciate the Korea National Academy of Science Technology to put this together. And then especially Professor Tae-sung Park to initiate this idea of the international symposium. So just like to conclude by saying this is the beginning of the further collaboration. And I think I'm going to get back to you perhaps pretty soon. Next time, we're going to have our European colleagues. And so we can have more conversation and more work together, more structured way if that is feasible. And as Alan noted. So that's I think the wish and I think the plan that we can have together. So thank you all again for having this conversation together. And good night, and good morning, and good afternoon, depending on where you are. And thank you all.
Okay, thank you for your participation.
Thank you very much. Bye.
Okay, bye-bye.
고생하셨습니다. 네.